Good afternoon, everyone. I hope you enjoyed your lunch, but we're going to get started with our afternoon session and hope to stick according to schedule for the rest of the day. So I'm pleased to introduce Jackie Herman, President of Cnets, for the Maureen Coleman Award presentation. Over to you, Jackie.
Thank you. So in the interest of time, I won't repeat what I covered yesterday with respect to the Maureen Coleman Award and how it was developed. It's obviously everybody knows that it's in honor of Maureen Coleman, the founding president, past president of Cnets. So we have these outstanding awards that we need to give out to some exceptional individuals from the past 3 years. So I'm going to start with Dr. Daniel Rayson. All of these individuals were nominated by the community, whether it's patients or colleagues, but most often it's been patients that they've been nominated by. So as you guys have all heard from Dr. Rayson, he's a medical oncologist and professor of medicine at the Dalhousie University, as well as division chief of medical oncology at the QE2 Health Sciences Center. Dr. Rayson fits the criteria for the Maureen Coleman Award as a result of the unmatchable effort that he makes to ensure that every NET cancer patient receives optimal care and follow-up. Dr. Rayson is known for his outstanding work in enhancing multidisciplinary care for NET patients, NEN patients, and in Nova Scotia by developing collaborative relationships with radiologists, pathologists, endocrinologists, and the nuclear medicine doctors. In 2013, Dr. Rayson developed a NET multidisciplinary tumor board, which I believe he continues to chair, correct? Yes. Dr. Rayson's training of oncology residents in NET care has resulted in the expansion of NET clinical resources throughout Atlantic Canada. Now, patients in smaller cities such as Charlottetown, Moncton, Fredericton, St. John's have access to local expertise. Thanks to his efforts, the Halifax NET team now provides NET clinical guidance and consultation for patients and oncologists throughout Atlantic Canada. Furthermore, every year, Dr. Rayson delivers well-received lectures for Cnets patient education conferences and several medical education lectures as well across Canada. Dr. Rayson supports NET research initiatives, which further enhances the role of Halifax as a center of NET expertise in Canada. Dr. Rayson's leadership in development and implementation of the Halifax PRRT program made Nova Scotia the first province in Canada to approve Lutathera for public funding. Eastern Canadian NET patients are now able to receive PRRT treatment close to home instead of having to travel across Canada. Dr. Rayson's dedication, calm guidance, and true caring approach to NET patient care is widely appreciated by the Canadian neuroendocrine cancer community. It's our honor today. Dr. Rayson, if you'd like to join me up here. I present you.
That was all very embarrassing.
Not embarrassing at all. 2020 Maureen Coleman Award.
Thank you very much.
You're most welcome. Our pleasure. You can say a few words if you like. Not to put you on the spot or anything.
I think Jackie said way too many. Thank you. Thank you very much, everybody. It's been a great journey, and it's going to keep going. Thanks.
Not to put you on the spot, sorry. I'll try not to do that, except with Dr. Law. So I'm actually going to have to call you up here again shortly. So Sharon Needham is the second recipient of the 2020 Maureen Coleman Award. Sharon is a lung neuroendocrine cancer patient who many of you may know. She's based in Halifax, Nova Scotia, and she has made an incredible contribution to the Canadian NET community through her work as a NET patient advocate and awareness raiser and a fundraiser. Sharon is well connected to the NET patient community, particularly online, and she provides support to her fellow patients on a regular basis. Sharon is a huge advocate for proper care and treatment for NET cancer patients in Canada. She has shared her very personal and moving story at conferences and through the press, media, and the QE2 Foundation in Halifax as the patient voice for raising funds to bring the incredibly important gallium-68 diagnostic to the QE2. Sharon has become a true champion for NET cancer awareness, which she sees as critical to ensuring better outcomes for NET patients. Sharon has also been an incredible fundraiser for NET cancer research, and as a member of the Cnets fundraising committee, she helped create the Hoofing It fundraising event that we hold now every year. Sharon was the top individual fundraiser in the inaugural Hoofing It campaign, and her team, Sharon's Angels, was also the top fundraising team. Sharon has also been a strong participant and fundraiser in past Scotiabank marathon events. Sharon undoubtedly has made an immeasurable contribution to the NET community across Canada. She is an individual whose positivity is infectious. She has a huge heart and a genuine caring and compassion for her fellow patients. She truly embodies the passion and the dedication of the Maureen Coleman Award. So it was our honor to present Sharon with the 2020 Maureen Coleman Award. Sharon's not able to be here with us today. She is enjoying herself in Costa Rica. So Dr. Rayson is going to accept the award on her behalf.
So I will say a couple of words about Sharon. Without her, we would never have been able to get gallium in Halifax at the time we did. She actually spearheaded the most successful fundraising campaign ever held at the QE2 Foundation, where we raised all funds within 3 weeks. I think the foundation's still, their heads are still spinning. She's really quite something. And if you have a chance to look at her video or fundraising video, I think it's an example of how well it can be done. So happy to accept it on her behalf.
I think that video is on our website, isn't it, Rico? Yeah, I think so. It's embedded in there somewhere. So 2019, I'm going to start with Vanessa Mann. Vanessa is the Hamilton, Halton, Niagara, Waterloo area co-support group leader. And she has been in her role with that group since 2014. She's made an incredible contribution to the neuroendocrine patient community through her work as a support group leader, a patient advocate, and an awareness raiser and a fundraiser. Vanessa is well loved, very well loved by the NET patients in her community and beyond. And she's very well known as a kind and compassionate person. Vanessa always makes herself available to support her fellow NET patients, listens to individuals' stories, and provides as much advice and information as she can. Vanessa endeavors to help everyone by sharing the right amount of information at the right time. She eases their minds and helps them better understand this complicated disease. She empowers patients to feel better about themselves, their NET diagnosis, and most of all, she gives people hope. In addition to Vanessa's work as a support group leader, she has raised an incredible amount of money for NET cancer research, first through several self-organized events, including her 2011, 2012, and 2019 Hikes for Help, her 2013 Canoe-a-thon, and 2018 Let's Talk About It online Facebook fundraiser. Since we launched the Hoofing It fundraiser, Vanessa has been a consistent participant, leads a team for Hamilton, and both she and her team have raised substantial funds. Vanessa sat on the 2019 Cnets Canada Fundraising Toolkit Committee, where together with other NET patients and supporters, she helped compose a fundraising guide designed to assist Others develop and execute their own fundraising events. Vanessa has made an immeasurable contribution to the NET community. She embodies the spirit and the dedication of Maureen Coleman, and it is our honor to present Vanessa with the 2019 Maureen Coleman Award. Vanessa is not able to be here with us today, but I understand that she's watching online. So Vanessa, we love you. We're sorry you can't be here with us, but I know that Stephen Medhurst is going to accept the award on your behalf. Thank you.
No problem. Just
Sure, go right.
and yeah, what Jackie said is absolutely spot on. And there's a few of us here in the audience from the Hamilton Halton based out of Southwestern Ontario support group that rely on Vanessa. And if you send her a message, she instantly responds. She's was a great help to me when I first got diagnosed, and she's just the most lovely, sweetest person I've ever met, and has become one of my best friends and support groups and mentor now, and I'm the co-lead in that area. So thanks, Vanessa. I know you're watching, and we all love you, and a lot of us are sitting right over there, and we're all rooting for you.
So the next award goes to Dr. Calvin Law. Dr. Law is a surgical oncologist at the Odette Cancer Center, Sunnybrook Health Sciences Center. Dr. Law's clinical practice is devoted to hepatobiliary, pancreatic, and gastrointestinal malignancies, and he has subspecialized practice in neuroendocrine tumors. As a co-founder of the Susan Leslie Multidisciplinary Neuroendocrine Tumor Clinic, Dr. Law is actively engaged in the treatment of patients with neuroendocrine tumors. Dr. Law has served in numerous leadership roles and currently is the chief of the Odette Cancer Center and regional vice president for Cancer Care Ontario. Dr. Law fits the criteria for the Maureen Coleman Award as a result of his incredible work in patient care and outcomes. He has brought hope to countless patients where there was none. Dr. Law is well known for his hands-on, caring, and compassionate approach, and in partnership with his NET colleagues, he goes above and beyond to ensure NET patients at the Susan Leslie Multidisciplinary Clinic receive the best care possible. In addition to being a hands-on physician, Dr. Law has given countless hours over many years to the NET patient community through Cnets Canada-sponsored patient education events like this one, and also to our medical events. He delivers complex NET surgical related education in a down-to-earth and simple manner with a humorous twist always. He always manages to get a chuckle out of his audience. Dr. Law makes himself available at these events to field patient questions, always providing sound and calm advice. Dr. Law's dedication, humble spirit, and true caring approach to patient care is widely appreciated by the Canadian neuroendocrine community. It's our honor to recognize Dr. Law's incredible contribution and present him with the very well-deserved 2019 Maureen Coleman Award. Welcome. Do you want to say anything?
Yeah, the one thing you weren't prepared for. Jackie, thanks for those kind words. Listen, you know, this means a lot, but you know, you come to work every day because you get to work with people like Jaydi and the colleagues that care so much. You know, I don't know if you can appreciate the kind of passion that some of my colleagues have, and they kind of inspire you, but that pales in comparison to the inspiration that we get from our patients. You know, I know that sometimes you have to be patient with us, whether it be waiting for us endlessly, or sometimes, you know, we're just so busy and we don't give you as much time as we want. But I need you to know that in the quiet times when you're not watching us, we're often talking about you, thinking about you. I mean, this is one group we really care about because of the journeys that you go through, and more, you know, more specifically, the courage you guys show brings us, it really just brings us more hope to work every day, you know. So thank you for everything that you do.
Okay, we have one more, last but not least, Dr. Simron Singh. Dr. Singh is well known, very well known in our community. He's a medical oncologist at Sunnybrook Odette Cancer Center, also at the Susan Leslie Clinic for Neuroendocrine Cancers, which he is also the co-founder of. Dr. Singh has devoted his career to improving the lives of NET patients and bringing global attention to NETs as a disease that matters. His expertise in health services research and quality improvement has been instrumental in not only improving access to clinical trials, but to use patient-reported data to improve the lives of patients today. Dr. Singh has worked nationally and internationally to improve access to treatments for NETs. For example, he led the development of the Cnets NANETS guidelines for the diagnosis and management of patients with lung neuroendocrine tumors, which brought together 3 different NET societies and included patient advocates to co-create best practice guidelines for this vulnerable patient group. Dr. Singh is also giving of his time and expertise at Cnets patients and medical events, and he is heavily engaged in many international medical societies and collaborations with the ultimate objective of enhancing Canadian patient access and the best standards of care. These are just a few of the highlights of Dr. Singh's contribution to the NET community, and it is obvious that he is passionate about this patient population and understanding and improving the NET patient experience. It is our honor to recognize Dr. Singh's incredible contribution to our community and present him with the very well-deserved 2021 Maureen Coleman Award. Simron. You're most welcome. Would you like to say something?
I guess I have to now, but thanks. Okay. No, just thank you very much. I don't want to age, but myself, but I've been about 15 or so years in practice, and when I first started, I worked with Maureen, and I was very new and trying to decide about different pathways in career. And Maureen encouraged me to get involved in NETs and to, when other medical oncologists really weren't interested, she kind of opened my eyes to a lot that was happening. I met her and I came to my first Cnets event at her invitation. So it's really a tribute to her that everybody's here, including me, that we're all here today. She was a really, I mean, Jackie's awesome as well, but she was a powerhouse that really pushed things off the ground. And so I guess we should all really just thank her for all getting us here. Thanks.
Now, I think Tracey's going to take us on to the next session. Oh, Tracey is the next session. Oh, I'm so sorry. I don't have the agenda in front of me. I thought Tracey, where are you? Over there. Come on up. I think you have all met Tracey Sherwood already. Tracey is a caregiver to her husband, Marty, and she is based on the East Coast, and she's one of the newest board members to Cnets.
I promised myself I wouldn't. This is my journey. October 9th, 2013, my husband called me and told me that he was having a heart attack. He was 40. He was driving himself to the hospital, by the way. I arrived 5 hours later. I was told his heart was good, but there was a large tumor pressing on his heart from his lung. And so our journey began. I'd been a caregiver before. I had helped my mom nurse my father back from open heart surgery. I had helped my parents transition my grandmother. But this was the hardest job I've ever had. And it was my job because Marty couldn't even tell you he had cancer. He would say, you know, that thing I have, honey. I educated myself. I reached out. And I, again, like everybody else, I can't thank Cnets enough. We had a wonderful support group leader at that time in New Brunswick, Annette Jonah. She was my angel. I drew strength from her, and together we grew our group. Our group does have patients, and I don't want to say the caregivers are forgotten about, they're not. But we're the ones that are picking up the pieces, cleaning up the mess, and I'm very proud to do it every day for my husband. And I hope I get to do it for many, many, many more days. We as caregivers, I don't want to say we're forgotten about. This whole weekend is about patients, but each patient has a caregiver. I will kindly ask if you are not a caregiver to stand, please. Stand up. Now, please give a round of applause to every caregiver in this room. And I'm under my 15 minutes.
Thank you very much, Tracey. I think it's very important to recognize the caregivers. We often focus on the patients, and very often the caregivers are in the background supporting all of us. So moving on, so we talked about the basics in the morning and the afternoon. We are talking about clinical trials. I'm here to call upon Dr. Singh. No further introduction needed, but I'll say 2021 Maureen Coleman recipient.
Thank you. So I've got two talks this afternoon, so thanks for inviting me. The first talk is really about clinical trials. I'm going to take 2 seconds to indulge here. I'm very thankful again for that award. And when we started, Dr. Law and myself started this clinic for neuroendocrine cancers. There wasn't really any standard pathway for care for neuroendocrine patients in the province. Dr. Law and myself went to our boss at the time. He's now my boss, but we went to our boss at the time, and we said, we'd like to start this clinic. We're thinking we should be working together more because the cases are complicated. And our boss kind of laughed at us and told us, this isn't going to work. And then we kind of kept pestering him, and he finally said, fine, you could have Friday afternoon clinic. And Friday afternoon, as you can imagine, is probably the least popular time for demand of clinic resources. And so we started that once a month on Friday afternoons. And as people who I see some familiar faces know, my clinics are all day Fridays now, and that's where that origin comes from on Fridays, is because we were sort of given, we had sort of no pathways, we had no standardized treatments, and now we have a lot of clinical trials, we have a lot of pathways. And so I think we're in a really, this is a really nice feeling to be able to come talk about clinical trials, because 10, 12 years ago, we couldn't imagine that we'd be able to even bring clinical trials to Canada, let alone have a choice of clinical trials now. So this is really great, and it's a kind of a testament to where we are as a community. And this is a partnership. It's a partnership between patients, it's a partnership between providers, healthcare providers, and it's a partnership between the industries that support us. So I think all of us all have to work together to make sure that we compete, because we are competing for resources, we're competing for attention, we're competing for making sure that people know that neuroendocrine cancers are the 10 most common cancers in the world, and that there's more people, of all the GI cancers, after colon cancer, the second most common cancer that people are living with out there is neuroendocrine cancers. But you hear a lot about pancreas cancer, and of course those are all important causes, but I think people don't really recognize how many people are living with neuroendocrine cancers or what they are. So all this work is important, and this is why it's been important to get clinical trials off the ground. Anyway, so, oh, you know what? It's the other one, sorry. This one is coming after this, sorry. Okay, so I'm going to talk to you a little bit about what a clinical trial journey may look like. Because as I mentioned, now in Ontario, when we have more options for clinical trials, this may be something that you or someone you care about may be facing a decision about a clinical trial. And hopefully we can talk a little bit about what clinical trials are and what do they mean. These are my disclosures. So what is a clinical trial? Well, it means different things to different people. When people think about what clinical trials are, things come into mind like research and test tubes. Of course, with COVID and the vaccines, we've all had very strong opinions about clinical trials now, and it's been in the news and it's polarized people. But I still think that, you know, clinical trials have existed. It's how we get to where we are today, the progress that's been made, and many of the treatments that we use, many of the techniques of surgery that are used, for example, are all come to us because we were able to test them in clinical trials. So what is a clinical trial? Well, I'm going to show you two sides of what people may think of it. It may be an opportunity. It may be an opportunity to participate in a trial where you get access to new drugs, where you're the first ones to get access to that drug that in 5 years from now may become the standard. It's an opportunity to be altruistic and to be part of this larger neuroendocrine community and to help others down the road. So even if you yourself may not benefit, it may benefit people who unfortunately are still going to face this disease down the road. And I think in this community, that is amazing. I mean, I've had clinical trials where people just had to give a biopsy or a sample, and that was it. And that was their, and nobody would ever say no. They always contribute because they want to help people down the road. And it's a new avenue of hope. It's an opportunity to be looking at what the next steps might be and to think about new doors that may open for you. But with a clinical trial, there's fears that come with it too. Am I going to be a guinea pig? Is this something that I'm going to be in a laboratory? I'm going to be tested on? I don't want to be a guinea pig. I wouldn't want to be a guinea pig. Are clinical trials all about big pharma making money? And, you know, there are a lot of clinical trials that are sponsored by pharma, and they are developing drugs, and that's how our system works. But at the same time, they're also developing new treatment options. Is it risky? Is this going to be safe? Has this ever been done? Am I going to be harmed by this clinical trial? And I'm not a test tube. You know, why are you testing this on me? I'm not the one that wants to be the person that's going to be tested upon. So clinical trials are voluntary. That's the most important thing to remember. No matter where you go, no matter what you do, clinical trials are voluntary. Nobody can put you on a clinical trial unless you consent. Nobody can force you to participate in a clinical trial. No one can cajole you into it. It's really up to you. At the end of the day, you make that decision, and every healthcare provider will support you whether you decide to or not participate in a clinical trial. This is a decision that is yours to make, and your caregivers. Clinical trials are studies conducted in people to answer specific questions. And those questions are, is something effective? Is something safe? And ideally, is it both? So a new treatment or a new way of doing surgery or a new way of doing radiation or a new order of treatments, these all can be things that we would test in clinical trials. We want to know, is it effective? Is it better than what we're doing currently? Is it safe? Is it safer than what we're doing currently? And hopefully it's both. And as I said, a clinical trial we often think of as testing a new drug, and that's primarily as a medical oncologist what I do. But Dr. Law may be doing a clinical trial looking at a new device in the operating room, or he may be doing a clinical trial looking at a new way of doing surgery. And clinical trials can even have to do with behavior. A clinical trial can involve how we change the way we deliver care. Is that better or not? So it doesn't always have to be a drug. What are the basic principles that are ingrained in clinical trials all throughout? The most important thing is to protect the health of the people in the trial. If there's any idea that this may not be helpful, that it may be harmful, a trial will never get off the ground, A, or B, it'll be stopped as soon as that it becomes clear. And it has happened before, where clinical trials happen and we realize, or the global community, once it's halfway through, realizes, well, there's a side effect here we didn't know about. The trial gets stopped, and it gets stopped at that time. On the other hand, there's clinical trials where it's stopped halfway because it's working so well, and it wouldn't be ethical to allow people not to get this drug anymore. So they stop the clinical trial and they say, no, this is a clear winner here. It's not ethical to randomize people anymore. And we'll talk about that in a second. It must be well designed. It has to be conducted by qualified, certified, and trained health professionals. So everybody who does a clinical trial has to go through training, has to get a certification, has to be, just not anybody can do a clinical trial. Even within the hospital, not everybody can do a clinical trial or be involved in a clinical trial. Everybody who touches your care as part of a clinical trial is certified and is qualified. it has to be monitored closely. And if my patients, for example, are part of a clinical trial, there's an independent group of people that are monitoring, which I'm not party of and I don't know the results of, to ensure that there's nothing, either it's not harmful or it's not so good that it wouldn't be ethical to continue and allow people to go on. And side effects have to be reported. So that's why when you're on a clinical trial, you're asked a million times about side effects, because everybody's being so diligent to make sure we fully understand the side effects, so people in the future can make informed choices about whether a clinical trial is right or wrong for them based on those side effects. And every clinical trial must be reviewed by an independent research ethics board. So for example, there's an Ontario, it's called OCREB, Ontario Cancer Research Ethics Board. That's an ethics board that covers all of Ontario. And they independently look at a trial and make sure that they have no ethical concerns. There's also hospital ethics boards, research ethics boards that all have to cover a clinical trial to make sure that this is done. So I just want you to know that there's a lot of background checks and balances to ensure clinical trials are safe and are effective and are well justified. So clinical trials may help prevent the disease, they may help detect it earlier, they may help improve the outcome of the disease, they may make life better for people with the disease. So there's clinical trials that look at symptoms, and I think in this community we probably understand that maybe better than some others. And it may help the disease from coming back. So clinical trials can help anywhere along the cancer journey, from prevention to diagnosis to treatment to recovery. There's 4 phases of a clinical trial, and I'm going to quickly go over these. Phase 1 is the first clinical trials, usually in humans. And they really are determined to make sure that it's safe, to make sure there's no side effects that are problematic that we were unaware of, and to determine what the right dosage might be, because it might be different. A drug that may work in renal cancer has a different dosage, for example, than the same drug has in neuroendocrine cancer. So it's to determine those points. Phase 2, I think of it personally as a little bit of the first check. Is it a thumbs up or thumbs down? So you test it, usually in a patient population like colon cancer, neuroendocrine cancer. Oh, this looks promising, let's take it to the next step. Unfortunately, at this level, about 3 out of every 4, if not more, drugs get the thumbs down. This is not working. There's no use investing more resources. There's no use asking patients to participate. This isn't going to work. It gets tossed out. And phase 3 is where it gets promising. This is where we think this is going to change the way we treat this cancer. And so it gets randomized and it's confirming that it's effective. And this is the most important stage. This is where it's make or break time. The government will decide whether the FDA or Health Canada will decide whether this treatment is effective or not. Phase 4 is after this. And it's like sometimes, and when you do a clinical trial and then it's released in the population, there may be some other signals that we never saw in very large numbers. Right? Some people may be clear with the vaccine, for example. There was a lot of debate about that. In the clinical trials, the side effects were some, but when we put it on the population, there was some debate. Did the myocarditis rate be a bit higher than what we saw in the clinical trial? That's the phase 4 part of things. Okay, so phase 1, it could be the first test in humans. It's usually very small numbers, 15 to 50 patients, just a handful usually. The goal, as I said, is primarily safety, understand the side effects, look for the correct drug dosage, and we want to make sure that it's efficacious. Often it's what we call disease agnostic. So the clinical trial might allow patients who have neuroendocrine cancer, but also patients who have breast cancer, also patients who have colon cancer. So it often isn't specific to any disease. And these are these aren't available anywhere. They're usually done at very highly specialized academic centers. In Ontario, the most phase 1 drug development trials would be at Princess Margaret Hospital, but there are other centers around Sunnybrook, Hamilton that also do phase 1. And the timeframes for these are short. These are usually small trials that are months. And again, this is usually for patients who have no standard options. Phase 2, as I mentioned, is bigger, but not a huge trial, usually less than 100 patients. This is the efficacious part of things. This is the thumbs up or thumbs down. And we're trying to see, does the drug work? Is it worthwhile investing more time, more money, and having more patients be invested in this? This is usually disease specific. It's usually for one disease. It also looks at safety, and the time frame is usually some years. Now, this is where sometimes we run into problems, and this is why I just want to put this warning in. Phase 2 trials, even if they're positive, doesn't mean they work. And that kind of sometimes goes against our intuition. Well, the trial was positive, it works. Well, not always. These are small trials, right? We're trying to weed out the bad ones so that we don't waste any more time or put anybody at risk. The ones that are thumbs up have to go on to a phase 3. And in fact, if you look, even in the trials that pass a phase 2, about 2/3 of them fail at the phase 3 level. So, you know, this was a drug, Avastin, that was on the front cover of Time after its phase 2. This is, we're going to cure cancer. Well, unfortunately, it didn't cure cancer, you know, because we don't want to overinterpret results of phase 2. Phase 3 is the pivotal step, as I said, and that's most of the trials that we do. This is, you're looking at hundreds to sometimes thousands of patients. They're randomized. It could be a single drug or in combination. And we want to know, is it effective? How many people need to be treated to see a benefit? And how effective is it? So is what we're saying. And, you know, is this really going to change the way we treat a certain disease? And we use something called randomization. And this is something that really scares people, to be randomized. Well, randomized can be blinded or unblinded. In many cases, it's blinded. When we say blinded, it means I don't know, you as a patient doesn't know which treatment you're on. And that way to do that, the reason for doing that is to stop bias, because all of us, including myself, if we have an idea of which treatment we're on, it may change the way we interpret things. If I know someone's on a new treatment, I may be hypervigilant to look for something, or I may take the opposite approach. Even if I'm not consciously doing it, subconsciously I might. And same thing for patients. They may worry more, am I on a placebo or not? So it has to account for that bias, and it's looked to balance it. As you can see here, this is how control randomization works. You have a group of patients, they're randomized to the control group. We see who gets benefit and who doesn't. And we can see here that there's a difference between the group. And this is what the purpose of randomization is to give scientific integrity to the findings, to make sure that bias isn't introduced. When do drugs get approved? And this isn't for funding, unfortunately. This is just for, is it for funding? This is just for, to make sure that we are able to get it approved for regulatory authorities. It's usually after the phase 3 point. So after this phase 3 trial is normally where we get the approval. Phase 4 is, again, after the drugs are being used in the population, we look at the real world experience. Sometimes the real world experience is that the drug doesn't work as well in the real world as it did in the clinical trial. Clinical trials are small, highly regulated, as I mentioned, situations. And sometimes when the drug is used in the population, it doesn't work as well, or maybe it works better. And sometimes the study populations aren't representative of what's actually happening. And, you know, some things may be like ethnic and race diversity. We have a very diverse population in Toronto, but the clinical trial may have a lot of patients from a different region of the world, and that may not be represented. There may be genetic differences to our population in Ontario. And in many clinical trials, due to safety reasons, they exclude people on the upper age ranges. And that doesn't mean that we wouldn't want to use that drug in those areas. Just to wrap up here though, who does clinical trials? Well, it's called the sponsor. And so whoever's sort of responsible for the clinical trial is a sponsor. It can be a drug company, and these are what we call pharma trials. It can be done by researchers, although this is difficult to do because funding is difficult. Pharma trials have funding that comes with them from the company because they're trying to develop a drug. Academic researchers, sometimes clinical trials, they do them, but they're a bit difficult because funding is quite difficult. They have to apply for grants, and the government doesn't give a lot of funding, as I think we're all aware of in Canada. So we do these things called cooperative groups, where we work together as groups, the United States, Canada, different parts of the world. We work together to do these clinical trials to try to build, make sure we're all doing the same thing and to build synergy. And these are called cooperative group trials. And then who approves clinical trials? At the end of the day, it's Health Canada and the FDA in the United States. And they ask questions like, is the drug being used the way it should be studied? Are the risks being lowered as much as possible? Are the best interests of the participants being taken into account? And I think this goes without saying, why do clinical trials, why are they so hard to do? They take a long time. They're very expensive. Accessibility is a problem. You know, if this trial is only open at Sunnybrook and you live 3.5 hours away, it may not be feasible for you to come back and forth. So accessibility can be a problem. Sometimes eligibility is too restrictive, where, as I mentioned in the trial may not allow, the ethics board may say it's not, we don't want patients over the age of 80 because we don't know the sum of this particular side effect, but then that becomes a bit restrictive. And then a lot of misconceptions. that they would, some of the misconceptions would be they're expensive to patients. Clinical trials shouldn't cost you anything. Clinical trials, you should, in fact, if anything, should be have more support for you. People are always worried about placebo, and there are some clinical trials that are placebo controlled, but they would only be placebo controlled if there was no other option. You would never have a clinical trial where there's an option available, but you're going to get a sugar pill. It's never going to be worse than the standard of care. That wouldn't be allowed. The ethics board wouldn't allow that. We wouldn't allow that. That's just not the way clinical trials are done. And like we said, I don't want to be a guinea pig. So we're just a bit short of time here. I'm just going to skip to my last slide here. Just going to give you an example. So if you are thinking about doing a clinical trial, and these are some of the questions you may want to ask. What are the benefits and risks? What's the purpose of the trial? Has this treatment been tested before? So what phase is it at? Will this improve my health? Are we talking about this clinical trial to improve for me or my partner or my caregiver, my family, or people down the road, or both? Who is the sponsor? What phase is this? What do you know about the side effects? Why do you think it will be effective? You know, people always ask me when we talk about clinical trials, is it going to work? Well, if I knew it was going to work, we wouldn't do a clinical trial. But I think it will, and I think there's enough promise in it to move forward. And I can tell you why I think it's going to be promising. I can tell you the rationale behind it, but I can't promise you it's going to work. What is the control arm? So if I'm not on the experimental arm, what is the control arm? What would we do if we didn't do the clinical trial? What would be my option at that point? What is the follow-up? Often in clinical trials, you have more follow-up. You got to come back more often. So that may work for some people. Some people like that. Some people don't. What do I need to do? I.e., how many trips do I need to make? Is it a journal I need to keep? Do I need to do a phone call every week? What does it mean for me as a patient? And overall, why do you think this trial is a good option for me? No one's going to present you a trial they don't think is a good option for you. So clinical trials aren't easy, but they're important. And I'll stop there. Thank you.
So we'll leave the questions for later then. And moving on, I'll invite Dr. Del Rivero back to talk about clinical trials at NHS and see if how our Canadian patients can take opportunity and take advantage of that.
Okay, thank you. So what we're going to discuss now is all the available clinical trials as well as future clinical trials at the National Cancer Institute. I have the fortune to talk to a few of our patients earlier today, and some of our patients has the experience to be there. So we're always happy to answer any questions. Okay. Okay. So I'm just going to start about what the NIH is. So NIH is a big building, and it had many different labs, research labs, where we run a lot of our studies prior to going to the clinical trials. So Dr. Singh mentioned earlier, before going into clinical trials, there is a lot of tests that needs to go into the lab. And we do have a lot of experience doing that. We also have many clinical as well branches, and I have a lot of collaborations with different members within the NCI. It has been also a journey for me to establish a neuroendocrine tumor center, but I have to say all of the hard work that we are doing, and we have a lot of more people interested in neuroendocrine tumors. So hopefully all together and forming collaborative efforts, we can definitely make a difference in patients with neuroendocrine tumors. The NCI is also known to have a very diverse group of investigators, not only in the lab, but also as well as clinical investigators. The goal is to be able not to only understand the biology of different cancers, from the genomics as well as different aspects, immunology as well as different cancers, but also to be able to develop clinical trials of tumors of unmet need. In clinical trials, we know that we discuss all about clinical trials, but the reality is that many type of clinical trials. There are natural history studies, there are treatment trials, there are screening trials, and there are also prevention trials as well. And neuroendocrine tumors is an unmet need to develop more therapies, and that's an effort that we're having also at the clinical center at the NIH. This is a slide. This is from Dr. Pamela Kuhns, and where we can see here, it was before the 2000 that there were not that many treatment options for neuroendocrine tumors. But we can see here that from the 2000 until now, there has been various treatment options available for neuroendocrine tumors. That said, there is a lot of treatments needed as well to not to only improve the quality of life of patients living with neuroendocrine tumors, but at the same time to be able to see more responses that we can currently see with the current treatments. And also, whenever I see these slides, it kind of gives me hope. And I think Dr. Singh and many others may agree that 20 years ago, there were not that many treatment options, but now we can see there is a few more. And there is a lot of people passionate about these tumors that really want to make a difference. And when I see that, I also feel hopeful as well. So what are the challenges in the management of neuroendocrine tumors? As we know, there are not that many FDA, even though there has been more in the last couple of decades, they're still not compared to breast cancer or colon cancer. I think there is a lot of more room for improvements and be able to develop more therapies for neuroendocrine tumors. But at the same time, there is a lot of questions about what is the sequencing, how long do I need to receive a specific therapy, what patients need to receive the very specific type of therapy. The immunotherapy question, like I heard earlier, is also a question as well. And there is a lot of unanswered questions. And also, some of the challenges as well as the neuroendocrine tumors are very heterogeneous. You heard that word earlier before, and also the management is quite personalized. So that can also originate a lot of uncertainty as well among patients and caregivers to determine what is the best treatment option. And that's something that we're trying to figure out by doing a standardized data collection. And that's something that we're trying to do through natural history study. Dr. Singh in our Cnets meeting say very nicely about being able to form collaborative efforts and have standardized data that we can follow during long periods of time to be able to understand more about the biology of these tumors. And that's a neat that we definitely need to implement. And that's something that since I started my journey in the management of neuroendocrine tumors, that's something that has been working as well and for more collaborative efforts for the management of neuroendocrine tumors. But moreover, patients with neuroendocrine tumors and their families face unique challenges. One of the reasons is because it takes a long time to diagnose. And very often when we diagnose patients with neuroendocrine tumors, they're already in advanced stages. They have a lot of medical centers. They have limited experience for neuroendocrine tumors. And what we're seeing is a lot of the patients needs to travel long distance to see an expert. And that's a lot. It's challenging for the families, challenging for the patients, caregivers. Moreover, the expenses associated with that is not easy for a lot of our patients. We discussed that there is no standardized treatment guidance, and that also creates uncertainties, and very often patients feel isolated. I heard throughout the day, I heard wonderful things about Cnets, and it makes me very happy to see that you have a wonderful organization who is always available for you and answer any questions. And I think patient advocacy and what you're doing is very important. And I think together with patient advocacy and patients, that will be a better way to also be able to understand more about neuroendocrine tumors and develop better therapies. And that's something that we're trying to also engage in terms of having more easily accessible national and international engagement network with patients as well with advocacy and support groups. NET researchers also has some difficulties because it sometimes takes a long time to accrue patients. Sometimes we need to have a multidisciplinary team, and not every center may be able to have that. Sometimes that creates some lack of communication and silos. As a researcher, there is some struggles. We don't have many preclinical models to be able to do drug testings, and that's something that we're trying to invest as well to be able to develop more therapies, but that's still a struggle. And also, one big issue about researchers is that there is less sources for grant funding for neuroendocrine tumors. So I think also trying to collaborate together with patient advocacy, physicians, researchers definitely can help us as well to be able to put the needs in the map, that this is what we need in order to be able to further the science and at the same time be able to develop better therapies for neuroendocrine tumors. And I will not go into what clinical trials. Dr. Cindy did a wonderful job going to the clinical trials, but one of the areas I do want to mention is that these clinical trials will help us to understand more about how different treatments work. But also not only to treat cancer, but at the same time prevent cancer, manage symptoms. There are different type of clinical trials as well. And that's where natural history studies plays a very important role. Natural history study allow us to follow patients over long periods of time, allow us to collect information, blood, imaging studies, saliva, to be able to do further questions or ask further questions to be able to understand about the biology of neuroendocrine tumors. But also the reason why we want working on these natural history studies, because we wanted to understand also how certain cancers form, growth or spread, also what genes can develop into certain families. And that's also an interest of mine. We discussed earlier that approximately 10% of neuroendocrine tumors may also have associated with familial syndromes. And that's something that I have an interest to understand further as well. But also, can we learn clues to help prevent cancer, and can also learn clues to help develop better therapies? And that's where the natural history help us understand more about that. We have a natural history study. A couple of participants here has been going to the NIH for some natural history studies, and also we can discuss more about their experience. But the natural history study allows me to see patients at the NIH and also follow patients over long periods of time. We wanted to understand more about how these tumors behave over time, to be able to then understand where is the needs to also implement therapies as well. This is a study that is available also for any Canadians, and any Canadian citizen can participate. The way it works is either the patient themselves or the referring physician send us all the information. We collect all the clinical information. We discuss that. We have a multidisciplinary team, and we discuss all the information about the patient, and based on that information, then we make the decision whether could we provide surgeries to those patients or any standard of care therapies. I have to tell you that Congress has making efforts in order to include more diverse populations, not only in terms of race, but also from other countries as well. And I think that's an important effort because we know that even within different tumor types and different populations may present also differently. That's something that we wanted to understand. And then because of that, Congress is able to help provide some treatments for also patients in need. We also discuss the possibility to enroll a patient in the natural history study, but if there is a treatment option that we think it may be beneficial, that's something that we also discuss with our patients. We also do virtual consults, so patient doesn't necessarily need to come to the NIH initially, but we provide virtual consults as well. This is just a schema of if the patient needs surgery. As you know, patients with neuroendocrine tumors, even in the advanced setting, surgery can still be discussed. I'm not saying that surgery may be for everyone, but there is a subset of patients that may benefit from surgery in the metastatic setting. And if that's the case, we do have the surgical expertise to also bring patients to the clinical center. And when that happens, we ask our patients, is they're able to provide a small piece of tissue from the surgery to do different genomic analyses and be able to develop models to be able to do different drug testing. And we're also trying to understand more about the tumor immune environment to be able to understand how we can improve that in order to then help the immune system attack the cancer cells. Earlier today, somebody mentioned about Dr. Carl Patza. He is also a collaborator and a mentor of mine, and he also have a natural history study, more on the diagnosis and molecular biology, meaning with imaging studies, as well as with genetic testing as well, to understand about pheochromocytomas and paragangliomas. We do have another study for neuroendocrine tumors, all GI neuroendocrine tumors, meaning gastrointestinal, any part of the gastrointestinal organ, including rectal neuroendocrine tumors, appendiceal neuroendocrine tumors, all from grade 1 to grade 3 neuroendocrine tumors. This is a study of Lutathera in combination with a pill called olaparib. Olaparib nalaparib has been approved for other cancers like breast cancer, prostate cancer, ovarian cancer. The reason why we wanted to combine the two of them is because we wanted to make Lutathera more effective. We know Lutathera works and it helps stabilize the tumor over long periods of time, but that say, could we make Lutathera more effective? And that's some of the research and studies moving forward. And that's why we have this study to understand by giving olaparib whether we can help patients to have better response by looking at the scans. And the reason why, in terms of understanding a little bit of why we came with this combination, is because Lutathera is a type of radiation. This type of radiation breaks the DNA, the tumor DNA, and what it's trying to do, our own system is going to try to repair that that DNA phenomenon that is happening. And because of that, by giving olaparib, we prevent that repair, and with that, we can make Lutathera more effective. So that's kind of like the rationale why we're doing this study. And then we have also a Lutathera study for pheochromocytomas and paragangliomas as well. I'm working together with Dr. Franklin for that. We also have another study for pheochromocytomas and paragangliomas. This is a randomized study with one of the NCTN groups. Dr. Singh will discuss maybe more about that. But this is a study that we randomize patients into two groups, either to get temozolomide or to get temozolomide in combination with olaparib. I'm fortunate to have co-lead this study with Dr. Perez from Dana-Farber, and we're currently accruing as well for this study. Temozolomide is already on guidelines to be for the treatment of advanced pheochromocytomas and paragangliomas, but similarly to what I discussed earlier with Lutathera and olaparib, we wanted to understand if by giving olaparib, can we make temozolomide more effective? And that's the question that we want to answer with this study. Just going to skip that one. We also have a lanreotide study for pheochromocytoma and paraganglioma as well. This is in collaboration with Dr. Fojo from Columbia University Medical Center. Lanreotide is approved for neuroendocrine tumors, GI and pancreas, but it's not approved for pheochromocytomas and paragangliomas. So we wanted to do this study to understand whether this treatment can help slow down the growth of tumors. And this is just my last slide on that. This is our NETs therapeutic programs in terms of having natural history study, but as well treatment studies available for patients. And we have an expert multidisciplinary group that has a lot of expertise in neuroendocrine tumors, not only for adults, but as well as for pediatrics. I'm not a pediatric oncologist, but I do work with a pediatric oncologist to see pediatric neuroendocrine tumors, as well as pheochromocytomas and paraganglioma patients. This is how you can take part of the study at the NCI. There is some information here, and these slides will be provided to you. There's a website that you can learn more about our infrastructure and how we can see patients. And we can, again, patients from Canada and all over can be part of the studies. This is a very nice website, and also my email is there as well. But this is a nice website that provides a lot of educational material and also a lot of information about clinical trials within the clinical center. And with that, I just want to acknowledge all the collaborators. It takes a village to be able to, work in these neuroendocrine tumors, to be able to understand more about the biology. We have formed a very large group of investigators and physicians within the clinical center and outside of the clinical center. But moreover, I just wanted to thank you and the patients and as well as the caregivers, because you're the most important part of this. You're our inspiration. You are the reason why we're doing what we're doing. And I really appreciate you allowing me to be here with you today. Thank you.
Thank you very much, Dr. De Rivero. Any questions for Dr. De Rivero? I think the most important thing that was on our mind is how to get access to or an opportunity to participate in her studies. And I think she did show the slides, and the slides will be distributed. So that's great. Oh, there is a question, sorry. Okay. AI? AIM in this kind of
You mean artificial intelligence? If we're doing, yes, actually, we're doing some spatial transcriptomics for neuroendocrine tumors. That's one of the projects that we're working on that. We're also working with our nuclear medicine physicians and correlate, findings on the scans, correlate that with the pathology findings. So we're working in some kind of like these AI projects as well. We also have we also doing whole exome sequence in neuroendocrine tumors, and also all that genomic information is then placed into a computer, a bioinformatic tool, and that all that information is what we hope is that information will help us understand which patients may respond to this, or patients that respond to a specific therapy, what are the molecular characteristics, so to understand whether we can discover any prognostic biomarkers. So meaning these biomarkers help us understand which patients may respond to certain therapies or which patient may have a more aggressive tumor type. And that's something that we're trying to also understand by doing this whole exome sequence and molecular testing in different tumors. Answer the question? Oh. Oh, yes. Yes, thank you for that. I appreciate it. Yes. So, so everything that we do at the NIH is free of cost. So all the treatments, all the scans and blood work, anything that is within the study is free of cost. So you will never get a bill. We don't require an insurance to do that. And we also support travel from the port of entrance to the United States. That said, there is also a financial assistant. So we have a social worker that help us to also do a financial assessment. And if that's the case and the patient is in need, we be able to support not only the travel for the patient, but for a family member in full support of a hotel, depending on the days that is needed to be part of the treatment or the study. And also, and if the financial assistance is not needed, for example, we still provide some funding that goes towards hotel and per diem as well. So I can, this is.
Sorry, I just have a follow-up question. Is it only at the initial time of presentation? Because there was any.
No, just once a patient is enrolled into a clinical study, is every time they come to the clinical center. As you know, clinical trials, if a patient wants to participate in the clinical trial, yes, they need to come to the NIH for the duration of the therapy. But with that, we do provide travel, so funding for travel as well, hotel accommodations, every time.
Thank you. Okay, so I'll ask Dr. Simron Singh to come back. Thank you very much. So we're moving on to treatment options. We've talked about the clinical trials. Now we're moving on to the treatment options.
Okay, thank you. Okay, I'm just going to keep on time here so I don't go over time again. So I've been asked to talk a little bit about what systemic therapy is. So I'm going to approach this in two ways. One, I'm going to just talk about what the basic systemic therapies are, which are the medications that we have available and sort of what's available right now. Predominantly, I'll speak to Ontario, but it's slightly different in each province. And then I'm going to talk to you, just going back to the clinical trials, about in terms of systemic therapy, which areas are we trying to improve on in clinical trials and what's available in Canada. So I think most people would hopefully know that the most common treatment we use for neuroendocrine cancers are somatostatin analogs. They remain the bedrock of treatment. Many neuroendocrine cancers, not all, but many have these receptors on the surface. And you've probably heard of two drugs, octreotide and lanreotide, which we use commonly in Canada. They act on these specific receptors that neuroendocrine cancers can have to slow down the growth of the cancer. Somatostatin analogs don't shrink the cancer, they don't get rid of it. You know, we talk about put it in a hibernation mode, try to get it to stop growing and just go into like a deep hibernation mode, hopefully for a long period of time. So somatostatin analogs, we have a few. Octreotide has been around in Canada for some time now. So this check mark means that it's funded. And I have a sort of a maybe funded because in some situations coverage still isn't universal, but in most situations it is. We have a short-acting version, pardon me. We have a short-acting version. which is given generally for symptom control to get it under control quickly, or for people who are having flushing or diarrhea. And then we have a long-acting version that's given every 4 weeks generally. Lanreotide, the same thing, although there's no short-acting version of lanreotide, it's just the long-acting version. And this is probably the most commonly used somatostatin analog in Canada. We're starting to see some changes come about in terms of somatostatin analogs. There's been some generic versions that have come through. Octreotide had a generic version come through last year during COVID. This transition has not gone well. Some patients got transitioned and didn't know, and sometimes it was a surprise. There's been a drug shortage. As of now, there's no more generic versions for new patients available. And I don't know what the future of that looks like. So it was a bit of a rocky transition to the generic octreotide. There is talk of a generic lanreotide as well coming to market later on this year, and we'll see how that goes. Right now, there's no Health Canada approval. Other things, which we'll talk about in clinical trials, new things in somatostatin analogs would be there's a new development of a high dose subcutaneous, so a much smaller needle somatostatin analog, and that's promising, but still at the clinical trial stage. And in fact, there's also a new development of an oral somatostatin analog, so get rid of the needle altogether. That's also in very early clinical trial stage, and we have both those trials open at Sunnybrook, so I'll talk to you about them briefly. Targeted therapies, these are things that act on certain targets in or on the cell. People like to think of them as silver bullets. Unfortunately, they're not really silver bullets. They help, but they're not silver bullets. They don't completely, even though they target the cancer, they don't eliminate it. They're generally oral. Everolimus or Afinitor is funded pretty much across the country, and that's that check mark there. It's been used in lung, pancreatic, and all GI neuroendocrine cancers. Sunitinib or Sutent, sorry, I have pancreas there, it's wrong, it should be Sutent, also has a check mark there. It's only used in pancreatic neuroendocrine tumors, probably used a lot less than it was when it first came out because we have other options now, but it's still used to some degree. And then there's a number of other, what we call tyrosine kinase inhibitors, which are types of targeted therapies, drugs like lenvatinib, cabozantinib, pazopanib. These drugs are also efficacious in neuroendocrine tumors. Unfortunately, in most of these cases, the drug company has decided not to go forward for an indication in neuroendocrine cancer, which means they've decided that they're not going to do a phase 3 trial like I talked about. But we try our best to get compassionate use or to try to find some ways to get drug coverage, and we really rely on our pharmaceutical partners to give us compassionate use when we need to use these drugs because they're not funded by the government. Sometimes people have private insurance, we can get payment for it, but it's a bit of a scramble sometimes. Chemotherapy has limited role still in neuroendocrine cancer. I think we should say that outright. There is some IV chemotherapy that's used, either cis or carboplatin and etoposide. These are very old drugs from the 1950s. They're given intravenous. They're really only given for what we call poorly differentiated or high-grade neuroendocrine carcinomas. So I tell my patients that neuroendocrine cancer sort of go in 3 lanes, a slow lane, a medium lane, and a fast lane. This is really only used in the fast of the fast lanes. So it's not used very much, but it is very useful for those people who have very aggressive neuroendocrine cancers, unfortunately. Streptozocin, some people may have heard of it, isn't really used anymore. And primarily for that is we now have coverage to this drugs called temozolomide and Xeloda. It's chemotherapy, but they're oral chemotherapy. They're well tolerated. Again, much like the injectables, things that you take at home aren't universally covered in our healthcare system. Dr. Law's going to fix that by next week, he told me. But you know, so we have these gaps, people under 65, et cetera. So we try to figure out with our drug navigators the best way to make sure everybody has coverage. But these oral chemotherapy pills are mostly available. They're generally well tolerated. They're very good in pancreatic neuroendocrine tumors, and there's some role as well as high grade and potentially in lung neuroendocrine tumors as well. PRRT, Dr. Wong's going to talk about, so I'm not really going to talk about it. I just included the slide to lay a little bit of a flag because we don't really know how to think about PRRT. So radioisotope therapy, it's sort of new. Everybody thinks of it slightly different. Is it molecular therapy? Is it internal radiation therapy? Is it systemic therapy or systemic radiation therapy? It's really a new era of personalized medicine in neuroendocrine cancers, which is exciting. But it does involve, you know, multiple specialties, including systemic care. Right now in PRRT, Lutathera is approved. In Ontario, it's approved for small bowel neuroendocrine cancer after progression of a somatostatin analog, so second line. In parts of the country, it's also funded for pancreas. We're hoping in Ontario it'll be funded for pancreas soon. We're waiting for the government to make decision. It's been recommended to be funded, but our government moves very, 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 very slowly on these decisions. And then we're talking now about retreatment. So maybe people who had PRRT now can be retreated with PRRT, and that's in clinical trial stage, and I'll talk about that. As of now, in PRRT, Lutathera is the only approved agent. Everything else is really experimental at this point. And then finally, in symptom control, we have a couple of agents that are available. Telotrestat or Zermelo is a drug that some people may be familiar with. It's really to help with patients who have carcinoid syndrome, so flushing, diarrhea, what we call functional neuroendocrine cancers. Unfortunately, it's not funded by the government. It's also changed hands. Ipsen used to own it, and they've sold it to another company called SERB, and that transition is just occurring. So we're still a little bit unclear about what that picture is going to look like. We're hoping that they will provide compassionate release. I applied for it for one patient last week and did not get compassionate release of the drug, and I've appealed it, and I still heard a no, so I've appealed it a second time. So I'm hoping that this is just a learning curve and we'll have a better access. And then there's a drug, the oral somatostatin analog called paloxetine, which we have a clinical trial running on improving symptom control with the oral pill rather than an injection. So that's a whirlwind tour of sort of the major where we are today in 2023. Just a quick update on where we are, how those clinical trials are. For first-line therapy, we have this trial running now, which is looking at a new high-dose subcutaneous somatostatin analog. It's called the Sorrento trial. As I mentioned, somatostatin analogs are the basis of treatment. We don't know if we're using them to their maximum capacity. You know, these drugs work. They slow the tumor down, they stop them from growing, they allow people to go on with their normal lives many years with the cancer. But the way we dose them have been sort of based on other diseases, and maybe there's more potential. Maybe we can get more out of them. I always like to say, you know, I want to squeeze this sponge fully before I throw it out and move on to the next treatment, which may be more toxic and maybe not as good. So this trial is looking at this, and when we start to think about what treatment we want to do, we want to make sure that our care is centered around the patient and that they have a better injection experience, but we also want to make sure we're doing quality care, that we are making sure that the data supports this and that we're using the resources we can. And somatostatin analogs meet all of this. So the question of this trial is, does long-acting octreotide above the standard dose or exposure or increased dosing frequency improve survival compared to what we're doing currently? And this uses a new technology. It's called a fluid crystal drug delivery system. And what it does is, it's a small injection of a little lipid ball that sits underneath the skin, and it gets absorbed with the water in your body, and it forms a little ball about the size of a pea. And this is then reabsorbed by the body over the next few weeks. But during this time, this little pea-sized thing that sort of exists in your body, it releases the drug at higher levels and at more constant exposure. So it's a better way of delivering the drug. So this is the new agent. It's called CAM2029. It comes like this. It's a pre-filled pen with a much smaller syringe. So anybody who's aware of the current somatostatin analogs we use, it's a much smaller needle and much shorter. So it's closer to people who take insulin. It's not quite as small as insulin needles, but much closer to that than the big needles we use currently. And this is just some data to show. This gray line here is the drug levels that occur with this new compound. This is preclinical, so not in humans yet, but in mice. And this is the normal levels of what we do today. So there's a potential 10-fold increase. Our goal would be that maybe this 10-fold increase would lead to better outcomes. Again, can't promise that, but it's a promising enough that it should be tested. And it's currently in a phase 3 trial. It's called the Sorrento trial. And this is how it goes. It randomizes people to receive this drug, CAM2029, versus standard treatment. So again, you're not going to get any treatment that you wouldn't normally get. And the nice thing about this trial is that if on the standard treatment it stops working, you can cross over. So everybody's going to get access to this new treatment, whether it be on the onset or after the standard treatment doesn't work. The trial's global. It's in 14 countries, looking for 302 patients. About 175 people have been recruited already. So we anticipate probably by the end of the year, this trial will be finished recruitment. Just a quick update. Some people may be aware of this trial called the Moderator trial, which looks at PRRT in first line, even before somatostatin analogs, and so more aggressive neuroendocrine cancers. This trial has now completed accrual, 222 patients globally. We have 222 patients globally, and we're waiting for the results, which we hope will be available this fall. So hopefully at this meeting next year, I'll have some exciting results that I can maybe share with you about first line PRRT. Now, if our government pays for it or not is a different story, but we'll deal with that when it comes to it. In symptom control, new trials, I talked to you a bit about this. This is pelocetine. This is the first oral somatostatin analog that's being used. So instead of injecting, it's a pill. And it is a 20 milligram tablet that's supposed to be taking on an empty stomach. This is the trial we have open, right? This trial is for symptom control currently. So this trial is not looking at does the oral pill control the cancer as well as the injection. It's looking at, does it control the symptoms? And the idea behind this is that, well, if it controls the symptoms as well, then it's justified to do a larger trial, a phase 3 trial, to see if it works as well as the injections. So this is the first step. So this is a phase 2 clinical trial. It's looking for, I think it's 60 patients globally. We're the only center in Canada that has this open. It's at Sunnybrook. And this is for patients who either have not been on a somatostatin analog before and have symptoms, or have been on a somatostatin analog but want to get off the needle and want to get on a pill. Okay, but this is really, again, for symptom control. And then I talked to you a bit about retreatment with PRRT. Those are 2 new trials that we're having open. This is a very exciting trial. It's called the retreatment trial. And the reason that is exciting is that this is the first time we have remember I talked to you about those cooperative groups that work together. For the first time in Canada, we are going to lead, and this is the first time in any cancer, we are going to lead an American clinical trial out of the NCI. So and we're going to lead this trial in the United States and in Canada from Canada. And that's the first time this has happened. So this is a really big thing for our Canadian clinical trials group. We're all very excited about it. It's open, it should be open by actually next week. We're just waiting for the final, it's been Health Canada approved and everything. And the way that this works is it's for people who've had PRRT before, and it kept the disease under control for a year, and now the cancers are growing again. Instead of putting them on some other therapy, we're going to try PRRT another 2 times. And that's where this comes down to. It's 2 times of PRRT, and the randomization is to what we would use normally, which is the drug everolimus. But again, this has crossover. So if the everolimus doesn't work, or it's not tolerable, then you can still get those 2 cycles of PRRT. This is not funded in Canada normally, getting retreatment. So this is a great way to get retreatment to PRRT, as well as hopefully it'll establish worldwide now. We're leading this for the world, not just for Canada, for the world. We're going to lead that retreatment PRRT makes sense, and we'll be able to open this door for patients who've had a good response to PRRT. And it was about, if you think like 10 years ago, that we were at these meetings lamenting that how do we get PRRT in Canada? Now that we have it, we're actually leading other countries and saying we think we should use it, retreat it for those patients who've had a good response. And then finally, there is a trial looking at a new type of PRRT called actinium-225. This is called the Action 1 clinical trial. I'm the global co-lead on this, so it's great that we're able to, again, get this to Canada. Dr. Wong will probably talk about this, and it's much more in her expertise than mine, but the differences between beta radiation, which is what we use now with Lutathera, and alpha radiation, which causes double-strand DNA breaks, etc. And this is, again, a retreatment trial. It's a slightly different population, but it's going to retreat people to this new type of PRRT called actinium-225 or alpha versus, and this is a decision to be made with what's best suited for the patient, whether it be everolimus, sunitinib, or high-dose octreotide LAR. And this trial it's just recruited its first patient in the United States. We're awaiting Health Canada approval, and we hope to have this open, I would say probably by September. And we have 2 local trials available. I just thought I'd mention them. They're not systemic therapy, but Dr. Meyerhog at our center, many of you are aware of, is running one of the largest trials in the world looking at the role of radiation on neuroendocrine cancers. He's collecting a very large series and is bringing the role of radiation to neuroendocrine tumors to the forefront. And we had this trial. This is also completed accrual. This looked at embolization and the different ways we could do embolization. So we're going to wait for the results of this as well. So I'll stop there. Thank you. Now,
Sorry, questions? We'll have a couple minutes for questions. No?
clear as mud.
Okay. Thank you, Dr. Singh. So our next speaker is Dr. Eve Simoneau. So she's general surgeon by training and then had her PhD in experimental surgery at the McGill University, following which she did a fellowship in the hepatobiliary surgery at MD Anderson and a fellowship in liver transplantation. She's a HPP surgeon and a liver transplant surgeon at CHUM with interest in HPP malignancies and oncotransplantation. Dr. Simoneau.
Thank you. I'm very happy to be here. Thank you for the opportunity to present today. I'll go over surgical options for small bowel and pancreatic neuroendocrine tumors. As a disclosure, I'm more of a liver and pancreas surgeon than I am a small bowel surgeon, but I'll try my best to honor the small bowel as well in this talk. So this is the overview. So as some of you, pancreatic neuroendocrine tumor represent 2% of pancreatic neoplasm that we see. Most of the time they're sporadic, meaning they're not associated with familial syndrome, which can happen in about 5% of cases. So as surgeon, sort of the first question we think about when we see a localized pNET is what is it exactly we're dealing with? So is it a functional or a non-functional tumor? And if it is non-functional, what's its size? So for functional pancreatic neuroendocrine tumors, such as those listed here that are hormone producing, really surgical resection is the recommendation. Obviously, if patients are medically fit. I'll go over some of these. I'll have some pictures too to show you exactly what they entail. So one of the options is enucleation, particularly for insulinoma, which has a lower malignant potential, so less chance of spreading to the lymph node and having distant disease. Otherwise, you have formal resection, which are distal pancreatectomy or the Whipple. Which lead us to our second question that we ask ourselves is, where is it exactly in the pancreas? So in order to do that, let's just review some basic anatomy of the pancreas. So you have the, on the left side, where the small intestine is, this is the duodenum, the head of the pancreas. So you have the uncinate process, head and neck, which is really tied closely to the duodenum with several vessels. And is, you know, this part is really wrapped around the mesenteric vessels, which are basically vessels that are supplying and draining the entire small intestine and also part of the large bowel. So we can, for the purpose of this talk, we can divide this into head of the pancreas, which are, you know, this region, and then the body and tail, which is, you know, as you can see, there's less traffic around that region of the pancreas. So it kind of makes the surgical management very different and a bit easier when the lesions are in the body or tail. So now I'm just describing, I just want to show you what enucleation is. So first we use intraoperative ultrasound in order to localize the lesions. And actually this is a nice picture, but it's not really accurate because most of the time we'll do this minimally invasive, so by laparoscopy or robotic. We tend to do that increasingly for this particular procedure and even other types of pancreatic resection. So an enucleation is really going around the tumor to try to preserve as much as possible the pancreas, but the lesion itself has to be away from the main duct, which is what's shown there in the picture on the left. Has to be at least 2 to 3 millimeter. Otherwise, you run the risk of injuring the duct and then creating a big pancreatic leak. So they tend to be associated with a little bit more leak than formal resection. And also it's really localized, so it should be used for a specific type of tumors. So non-functional pNETs, so those who are not producing hormones that are localized, really still, despite many studies trying to challenge this cutoff. So the recommended guideline is still to operate on those 2 centimeter or above or greater than that, because of the likelihood of these tumors having positive lymph nodes. So that's really why the reason why we're operating. So for non-functional pNETs in the body and tail, as we said, so on the left side of the pancreas, as you can see here, the operation of choice would be a distal pancreatectomy with splenectomy. And I put an asterisk there because I do want to talk about splenectomy. It's one of the most commonly asked questions in the clinic. Why do we have to take the spleen out? And can we preserve it? And so I'll discuss that briefly. So, but that's basically the standard operation for the lesions in the body and tail of the pancreas. So, and the standard way of doing them is now by laparoscopy or even robotic. Robotic is a little bit different because it depends on if you have access to the robot. It's a bit more challenging in the Canadian healthcare system, but definitely there's a lot of studies showing significant advantage of doing laparoscopic or robotic surgery for distal pancreatectomy, as it was shown to really improve the recovery of patients. And of note, also robotic is probably associated with less conversion, meaning like having the need to open, because it's probably technically easier, or ergonomically most surgeons would agree that it's a good tool to have, the robot. But overall, this is really the standard of care to do it by laparoscopy. We do have to consider some things though when we consider someone for laparoscopic surgery. We have to consider the size of the tumor. These studies were tumors that were 8 centimeter or less, and also it depends on the comfort of the surgeon to take out bigger tumors by laparoscopy. Also depends if it touches other organs, and so if you have to resect parts of the other organ. It really will depend on the expertise and volume of the surgeon and the center. So talking about the spleen, so can we preserve the spleen when we do distal pancreatectomy? So first of all, how do we preserve the spleen? And in which situation for neuroendocrine tumor can we preserve it? So there's 2 ways of preserving the spleen. So one way on the left, so it's basically detaching the pancreas from the 2 vessels that are going to the spleen, which are the splenic artery and splenic vein. This is a more meticulous dissection. You do have to tie up individual branches, but this is one of the way that you preserve the vessels going to the spleen. The other technique would be the Warsha technique, which the vessels going to the spleen are basically ligated, as shown here, and the spleen is supplied by blood from vessels coming from the stomach. So these are 2 different techniques that we can do. And really for neuroendocrine tumor, in which situation can we preserve the spleen? I would say probably insulinoma, which is the functioning tumor that has a lower malignant potential. If you can't enucleate, maybe you could do that and spare the spleen. But otherwise, most of the time when there's an indication for surgery, there's also an indication to take the lymph nodes around, which is the reason why we're taking the spleen out. So splenectomy still remains indicated in majority of the scenarios. So pancreatic head lesion, the other part of the pancreas, it's the pancreaticoduodenectomy, so the famous Whipple, which a lot of people read about before they come to clinic. This is a much bigger surgery, so that's why, like in terms of decision making, you have to take that into consideration. Where is it located? It's more morbid, and the recovery is different than doing the distal pancreatectomy. Because the head of the pancreas has the bile duct that goes into it and is tied to the duodenum, you do have to resect all of that, and you have to do 3 connections afterwards to the pancreas, from the small bowel to the pancreas, to the bile duct, and to the end of the stomach. So the recovery is really different. It is our routine procedure, but it certainly changes the life of someone who's undergoing that type of operation. So Can we do it by laparoscopy? It is done, but way less commonly. Most of the time, standard will be that surgeons will do it open still, although there's more and more interest to do it robotic. Just a few words about the non-functional pNET that are a little bit smaller. Sometimes we do resect them, but it really depends on other variables. For example, if it changed over time, if you're following them and they're still changing, but they're still less than 2 centimeter, we're still gonna consider that. Where the lesion is located, if it's in the tail, way easier discussion than if it's in the head of the pancreas because of what I talked about. The grade also, which is why it's useful to have biopsy, even during surveillance. And also patients' wishes. For some patients, it's very stressful to undergo surveillance that are increasingly frequent. And so sometimes we'll take that decision to operate a little bit earlier when it didn't reach the cutoff per se. So pancreatic NET can metastasize to the liver. So I just want to discuss like briefly some scenarios that we can encounter. So you can have someone can present with resectable, so operable liver metastases with pancreatic tail or head lesion, and they will be managed differently. You can also have unresectable liver disease and pancreatic tail or head lesion, and all of these scenarios will kind of be approached differently. But principles are, so if you have resectable liver disease and you have a pancreatic tail lesion, usually a combined resection, so doing the pancreas and the liver at the same time will be preferred. But it really depends on the extent of surgery. If you have a very complex liver operation to do, in addition to the pancreas, it might be increasing your risk of having complications, or it might be a little bit too much or technically difficult for the surgeons to do. So in that case, that surgery will be done open. But if it is possible for recovery improvement after the surgery, to do it minimally invasive is better. Otherwise, you can always do it sequential. And the order, whether you start with the pancreas or the liver, is not that much important as the following scenario. So if you have resectable liver disease and you have a head of the pancreas lesion, then the order of how you're going to do it is more important, because when you do a Whipple, which is the standard procedure for head lesion, you cut the bile duct and then you sew it to the intestine. So that will colonize the liver with bacteria, and it puts the liver at more risk for abscesses if you're going to do local regional therapy on your liver, whether it's surgery or ablation or embolization. The liver will be more at risk for having abscesses. So because it's seeded by bacteria. So that's why if you can do a combined resection, meaning to do the Whipple and an intervention in the liver, but it has to be a really small intervention because the Whipple takes a lot of physiological demand to heal, and so it cannot be a big liver resection with a big pancreatic resection. So it can be done in selected cases, but if you have to do it one after the other, you have to start with the liver because of the risk of abscess. So otherwise, you have if you had a Whipple and then you're going to do an intervention in the liver, you have a risk of abscess of at least 15%, which is considerable. Last scenarios, which I put together, if you have unresectable liver met and pancreatic primary, so there's a lot more undefined data. So the benefit of resecting the primary tumor if you have unresectable disease is very variable. There's no super solid data. Some studies suggested maybe could improve the response to PRRT, but it's still not part of the official recommendation. All of that to say that we need to consider factors like, is this a functional tumor? Patient factor, obviously, the ability to tolerate procedures, and the tumor localization. Again, tail of the pancreas is way easier because it's less morbid, doesn't prevent you from doing further liver intervention after. So it really is a case-by-case scenario. Small bowel NET, I will mention some things about small bowel NET. So surgical principle is really an oncological resection. It's not the same as, for example, the small pNET secreting insulin, for example. So it's really an oncological oncological resection with harvesting the nodes around the tumor, and you also have to resect the fibrosis, all the scar tissue in the mesentery leading to the tumor. So the principle, so most standard will be an open procedure. The role of laparoscopy is less because the steps you have to do are a little bit different, and it really requires you to do a careful examination and digital palpation. For example, you have to run the small bowel. This is like a major principle because you will have multifocal disease, so several primaries in the small bowel in up to 44% of patients, and several primaries that were not necessarily detected on preoperative imaging. So you have to do it, and the ability to do it with laparoscopy, which is basically small instrument, is way less. You have to use your hand for that. Also have to examine everything in terms of liver, peritoneum, and ovaries. So it's a different thinking than the pancreatic net. Most surgeons will also, if they're operating for small bowel net, will consider doing a cholecystectomy, not because there's anything wrong with that, but if you plan to do further in the future intervention in the liver, it can put you at risk of having ischemic cholecystitis. You're affecting the blood flow to the gallbladder by doing certain intervention to the liver. So since you're there, it's safer to take the gallbladder out. In terms of lymph nodes, so just the principle is you have to try as much to get to the lymph nodes. So, and the lymph nodes are basically can be very close to the tumor or higher up in the bigger branch of the vessel supplying that part of the bowel. So you can have lymph nodes that are very close to the tumor. You can have lymph nodes that are a little bit more distant, but still in a reasonable territory. And so you have to resect that small bowel, kind of a pizza slice with the lymph nodes en bloc meaning in one resection. If you have higher lymph nodes, so level 3, so these are a little bit higher and like bigger branches supplying way more small bowel. So what you'll do is you'll resect the part of the affected tumor, and then in a separately taking all these nodes that are around the vessel, but you're really trying to preserve as much as possible the vessel supplying the bowel. Because you don't want to cut off the blood supply to the big portion of the small bowel. And level 4 is really high up at basically the root of these mesenteric vessels, so it's usually considered unresectable and treated as such. And just because I do liver transplantation, I had to talk about onco transplantation, which is really one of my interests. So if you have neuroendocrine liver metastases with liver limited disease, but that is unresectable, it is a surgical option that's definitely not standard of care and still being discussed heavily, but transplant oncology is really a rapidly evolving field. So this is an example of the largest study that was done in one single center in France that looked at over 200 patients who had liver transplant for neuroendocrine tumor liver mets. And they actually had a very good survival. So if you see the curves, when they had favorable factors, the survival was up to close to 80% at 5 years. Patients were alive with a functioning graft, which is very good. They did identify in their work that some factors are more negative when you undergo transplant. In their study, they had hepatomegaly, so to have a very large liver, a certain age cutoff, although now this is not really something that people are using in reality, that age cutoff. But to have the resection of the primary tumor combined with the liver transplantation was very negative, so it's actually never being done. So you have to resect the primary before liver transplantation. Just quickly, this is a review of 64 studies that looked at liver transplantation for NET. And just the main points to remember is that a pancreatic primary, although some studies thought that maybe it's associated with less good result, lower survival over time. It was not, there was very acceptable survival in other studies. And, on 64 studies, only 4 analyzed the primary site and the outcomes. So pancreatic primary is not considered, it is not a contraindication for liver transplantation. The survival is good with selected patients between 60 and up close 79% in one study. The type of donors that were used in these studies most of the time are cadaveric donors, so meaning it's not a living donor that gives their liver, which is the case for mainly, which is often the case with newer orphan cancer indication for liver transplant. And the indication for transplant, why we're doing the transplant, was different in the study, sometimes for oncological reason, sometimes because of the bulk of the tumor or the symptoms. This is the US recommendation. It's actually the same that we're using in Quebec at Quebec Transplant. We do have a system that we can list patients after they've been extensively discussed and reviewed at multidisciplinary tumor board and with hepatology. And so we don't have an age cutoff less than 60 years old, but in the US at the time, that's what they use. So you have to have unresectable, liver limited, so only in the liver metastases, less than 50% of the liver involved, G1 and G2 tumors. And the primary of origin has to be removed more than 6 months before you get the liver transplant. You cannot do the two at the same time. And it has to be a primary that's being drained by the liver. Basically, small bowel, pancreas, stomach. And patients undergo the standard radiological surveillance. So take-home message, so surgery is the only curative treatment option for localized pNET and small bowel NET, but it is a very heterogeneous tumor, so the treatment decision can be complex. It really has to be individualized. It's the best strategy. Multidisciplinary involvement is really crucial. And the role of liver transplantation in selection criteria still have to be defined, but there's probably going to be more data soon to come. Thank you.
Thank you, Dr. Simoneau. I think we'll leave the questions to the end. In the interest of time, we'll move on to the next topic, liver-directed therapies by Dr. Mujoomdar. Dr. Mujoomdar is an interventional radiologist specializing in liver tumors at the London Health Sciences Centre and Associate Professor of Radiology and Oncology, Western University, London, Ontario. Dr. Mujoomdar is also Board of Directors of the Canadian Interventional Radiology Association and Canadian Association of Radiologists. He specializes in liver-directed therapies of the primary liver cancer and neuroendocrine tumors. Dr. Mujoomdar.
Thank you for the kind invitation. Just want to talk a little bit about some of the interventional radiology therapies for NETs. Lots of different treatments are evolving, but we still have a space with this disease. Let's see, perfect. So these are some of my disclosures, some of which are relevant for the talk today. Sometimes I would just like to take a step back. I don't have, the publicity like, surgeons and oncologists. When you say interventional radiologists, people are like, what the heck does that mean? And who are you sending me to? So I just like to kind of just clarify a little bit about what is the role of the interventional radiologist on the team, and and then talks about different types of therapies in terms of ablation. Some of these arterial therapies, we call them, where we're going inside the plumbing and either blocking it off or injecting the chemo. And then talk a little bit about what is the patient experience, something for the caregivers to look out, and talk a little about the risks and side effects as well. So the role of IR. So, we kind of wear two hats sometimes on these teams, where the diagnostic radiologist or radiologist is really that doc who's interpreting the imaging. So sometimes there's a radiologist on every tumor board that's there to review the imaging and discuss the findings. But really the physician that spend a little extra time focusing on therapies or image-guided procedures using different things like ultrasound, CAT scans, live x-rays. I can't say that image-guided is unique to me, because many of the docs in the room here use endoscopy and use, all kinds of, different imaging tools in their practice. But for us, it's really diagnostic imaging like ultrasound, CAT scans, live x-rays. That's the interventional radiologist. And some of us really specialize in interventional oncology. And then some of us are even more specialized to really treat neuroendocrine cancer, which does require an expertise unto itself. So what kind of procedures would you have met an interventional radiologist for? Well, sometimes as simple as a biopsy, which many people in this room, that's probably where their journey might have started with, right? It was an imaging and then a biopsy. I don't think this applies as much in the neuroendocrine setting, but we do place a lot of venous access devices, sometimes something as simple as a PICC line, something as more complex as a portacath. But really the things that you may have met us for is things like up for ablation, kind of what Jason was talking about earlier today, or some of these arterial therapies, whether it's bland embolization, which I'll kind of get into what that is. It's not a boring procedure, even though we call it bland embolization, or chemoembolization, Y90, or which we kind of like to call selective internal radiation. So what are the goals and cares when we're doing these different types of procedures? So I can't, like Dr. Simoneau, say I'm going to cure you and really do these amazing things. Most of the time, what I'm doing is I'm really doing a palliative type of therapy. I'm trying to control the disease as best as possible. Once in a while, I can really go for cure, but even when I'm going for cure, I do know a lot of times there's probably going to be some of that microscopic disease left behind. I would say some of the time we're really controlling symptoms and trying to stabilize things in the liver. So people that have functional disease, people that have what we heard, some of the speakers talking about earlier, take carcinoid syndrome, right? So we're, a lot of that is really driven by the liver metastases. So by trying to control the liver metastases with these arterial therapies, we're trying to control some of the symptoms. Sometimes, and I would say this is happening a little bit more and more, I'm trying to bridge a patient, maybe for something like a liver transplantation or an operation, or I'm trying to downstage a patient. For the liver surgeons, they need a certain amount of liver to be able to do that operation. So sometimes I'm doing procedures to kind of fatten up the liver so that a patient can successfully undergo an operation. And as I mentioned, very occasionally am I going for a cure. So when we talk about ablation, it's not really a common procedure that we use in the neuroendocrine setting. I would say most patients at diagnosis don't really have small tumors in their liver. They tend to show up with bigger tumors in the liver, okay? But this treatment option is potentially curative, and it is a minimally invasive way to treat liver tumors, okay? And really the goal and the principle is really to destroy the tumor while minimizing the damage to the kind of surrounding vital structures in the liver. But you also want to achieve a margin. So a surgeon, with the exception of insulinoma, isn't usually plucking out the tumor. They're getting the tumor and the tissue around it because they want to get all that microscopic disease. So we want to do the same thing. And our goal really was to try to improve the survival or decrease your symptoms. And we have a few tools in our toolbox, but largely it's with something called RFA or radiofrequency ablation, or more commonly with microwave ablation, which is a bit of a fancier version of that, and rarely with these other types of technologies called cryoablation. IRE is not really something in widespread use all across Canada. And that's kind of an example, is really we're putting an ultrasound probe on top of the skin, trying to localize this tumor, and we use that imaging expertise of being able to interpret the MRIs or CAT scans or whatever type of imaging someone has had to really localize where that is in the liver, and to sort of plan our I don't want to say attack because that sounds terrible, but plan our approach, I should say. And then we would put a probe into the liver after you kind of clean it, freeze it, and it's done in different ways. Sometimes it's done under an anesthetic, so kind of similar to an operation, or sometimes it's done when patients are awake and they get what's called moderate sedation. So they're awake, but they are kind of snowed with tequila shots and IV medications. And what does that look like? This is kind of a video I like to show. It's not a patient with neuroendocrine cancer, but the principles are the same. And back here, there is a tumor, and we kind of, you can see a big white line. All of this is the surrounding liver, and we basically kind of shish kebab it with our needle, really trying to precisely place it. Look, even though this is a two-dimensional image, we're trying to respect the 3D geometry of that tumor, and then we sort of burn it. And when you burn it, you kind of get this kind of gas appearance. And I'm sure in Dr. Simoneau's OR, she probably does some intraoperative ablations as well once in a while, and this is exactly what you see. You see a lot of this echogenic air that really makes your ultrasound image look a little bit useless, but it makes you feel like you're actually treating the tumor. So what's the patient experience when we're doing that? So usually it's an outpatient procedure. We don't have to admit people to hospital for that. And we generally give you an IV so that we can sedate you. And they're done in an imaging suite, whether it's a suite that has a CAT scanner or we just use ultrasound only. And like I said, most centers will use IV sedation. I will rarely use a GA. And the burning can be a little bit uncomfortable, so we try to snow you. So we sedate you right around the time we're about to turn on the machine. And then patients would go home with some medications after a few hours of observation, and then I'll see you back in the clinic, usually about a month afterwards, and I'll repeat the imaging. We do a bit of a before and after, and then sometimes we'll do blood work, but I would say most of the time the imaging will kind of tell us where we're at. What are the risks? Really, bleeding, I would say, is the biggest risk of any needle in your liver, okay? But even with that, there is a bit of a cautery effect when we're taking out our needles, so that risk becomes less. Infection can occur, and certainly can occur. Kind of what Jason was talking about is when you've had any kind of procedure that involves the liver. So if they have a bile duct connection, whether it's a Whipple's procedure, we would probably avoid doing ablation just because that risk becomes much higher. But we would do it in certain situations. They definitely have to have antibiotics for a few weeks, and even then, that infection can happen months down the line. Kind of what Jason was talking about. We worry about collateral damage, right? So in that case I showed you earlier, I didn't point out, but the diaphragm was nearby. So we don't want to, burn. We do want to burn some normal tissue, but we don't want to burn vital tissue. We don't want to burn things like the bile ducts or any major blood vessels. We will burn lesions near the diaphragm, but we obviously don't want to cause any damage to the diaphragm. And we really want to avoid burning anywhere near the colon or bowel, because we take a minimally invasive procedure and make it much more invasive. And then we have to call our surgical colleagues to assess the patients and potentially fix that. But I would say despite that, the risks are relatively rare, but the biggest thing we worry about is bleeding. Who should we treat? Really people that have a few liver metastases that are small in size and amenable to ablation. However, once again, if they are actually amenable to a surgical resection and the patient is a candidate, we would steer patients more towards a surgical side. I don't really get into the role of surgery versus ablation. I think if there's an opportunity to cure a patient with surgery, that's been our typical approach. Or sometimes they will actually get a resection plus or minus an intraoperative ablation. We will occasionally and rarely do a debulking ablation, and that would be more in the setting of, if it was not amenable to some of the other therapies that I would talk about, not amenable to surgery. And then we would consider debulking ablation in a bunch of spots where I know I'm not going to be curative, but we can either improve their symptoms or just debulk some stubborn disease that's been resistant to different therapies. But as I mentioned, it's a less common treatment. This is really the mainstay of what I do, is more these trans-arterial therapies or therapies through the blood vessels, right? So this is a nice picture that was actually in an article in the New England that I've stolen and used in many talks, right? So now this is kind of showing a different disease type. This is primary liver cancer, but the principles are basically the same. Is you have this, kind of monster tumor in the liver, and we kind of sort of split the liver into right and left using different anatomical marks. So this is pretty big when it's even pushing over into the left. And the principles are that really the liver tumors tend to be fed by the liver artery. I won't get into a big complex discussion, but the liver has a double blood supply that we kind of take advantage of in interventional radiology, that the primary blood supply of the liver is not as affected when we go into the arteries and kind of, embolize with tumor cell. Go back one there. So we would kind of get into this big blood vessel, and a lot of times we're either going through the wrist and the groin. This is a pretty simple picture that just talks about the groin, but depending on where you go and the expertise of the center, we do a lot of these through the wrist as well. And we would basically, get into that artery that's feeding the liver, called the liver artery or hepatic artery, and we shoot dye, just like people would get in their heart, to kind of map out that anatomy. And there's a different patient, but which is probably not that smart, because the docs in the room are saying, hey, that angiogram doesn't match the bigger picture. But and then there's a big tumor here. Okay, we could see other arteries that are feeding the spleen and feeding the gut, and that are gone in the Whipple procedure, and we can see some kind of dense blush along the pancreas. But this is the blush that we worry about, and this is key for me as an interventional radiologist, because we don't want to mess around and inject chemo or Y90 or bland particles and affect these organs here. So we have to kind of navigate our way using the live x-rays and the tools that we have with these little catheters and little wires to kind of park ourselves somewhere up here to properly treat the tumor, spare as much normal liver as we can, and spare other organs. So, we do different types of procedures. If you go see Dr. Law's colleagues in Sunnybrook, they'll do something called a bland embolization. But you know, at my institution, we primarily do chemoembolization, but both procedures involve liver angiography, kind of like what I showed you, that angiogram, where you kind of go through the arteries, inject dye to map things out. In the case of a bland embolization, they'll take these fine kind of calibrated particles and inject them into a tumor that will basically choke it of its blood supply. In the case of a chemoembolization, we'll take a chemo mixture. Generally speaking, we like this oily mixture with this substance called lipidol that's very dense on x-rays. We mix it up with a watery chemotherapy mixture. It looks like salad dressing, and you add some x-ray dye in there and a little bit of salt water, mix it all up and inject it. And then we will also chase that with some material that will block the arteries. That will also be directly toxic to the tumor cells with the chemo, but we will also choke it of its blood supply. Usually, at least for the chemoembolization, we kind of admit patients to hospital to kind of manage some of the symptoms. That's a bit of a rough day. And then we give people medications prior to it to anticipate some of those symptoms. How does it work? As I mentioned, we're going in this principle of choking the tumor of its blood supply. And then with the chemoembolization, we're looking at being toxic to the tumor cells as well as choking of its blood supply, a bit of a 1-2 effect. What's better? You know, as Dr. Singh mentioned, you know, I think the RetNet will help settle this debate. You know, neuroendocrine is such a rare disease process that the data that's out there is not great data. It's a lot of very single center experience. And even when they do these bigger analyses where they'll kind of collate a lot of the single center experiences, it's very hard to compare because the way things are done at different centers is not the same. So I think the RetNet as part of this trial will help answer whether the bland or the chemo is better. Or they'll tell us it's the same, we'll be back to where we started, but hopefully not. But we happen to do chemoembolization at our center. A lot of it is historical, and at least it's the same. And I personally believe that, but I don't have data to back that up. That I do think it's good. But there's a bit of a trend towards better outcomes in the pancreatic world. We don't know in the small bowel world. What are the risks? Well, really, theoretically, you could have bleeding where we poke you, whether it's the wrist or the groin, or any damage along the conduit, right? We could damage any of the arteries. You know, younger patients, it's usually not an issue. It tends to be more in the older patients. If you have vascular disease as well. If we're very aggressive, we can cause actually damage or an infarct to the liver, which is really killing off that part of the liver. We could cause a liver infection, okay, or which can lead to a liver abscess. Some of those particles or chemo could actually go outside the liver, and we could damage, you know, different organs like in the stomach or pancreas. The more common things, though, I would say, is really people just feel they don't feel great after this procedure, right? You get this post-embolization syndrome, which really you get these kind of flu-like symptoms. You know, you get tired. Tired is probably the biggest thing people feel is fatigue. Rarely you can get liver failure if you're over-aggressive, and carcinogenic crisis if patients with carcinosis, so we have to really pre-medicate patients well. Patient experience, as I mentioned, involves admission to hospital, and we really try to mitigate some of the symptoms, but it is a rough day. It is a rough day usually that day, but most of the time patients are gone by the next day because they sleep better and in their own beds and are able to kind of mitigate those symptoms at home. But you do have to worry about some side effects, even though it's targeted chemo. Sometimes you can have hair loss and things like that, depending on the doses. I'll talk quickly about Y90. So radiation we know is lethal to cancer cells, right? And it's used quite a bit in cancer. But the liver can be a bit of a difficult area to treat just because the normal liver is also quite sensitive to radiation. So we have this technology that really gives these focal high points of radiation that we deliver through the blood vessels into the tumor and really try to spare the normal liver. So the Y90 can be delivered by these little tiny microscopic glass or resin microspheres on the order of millions. So there's a little vial that you can't even see them with your naked eye, and they're quite powerful. You know, the half-life is about a few days, and usually by about 3 half-lives, it's kind of things are sort of you know, kind of gone. But the Y90 is working up until 3 to 6 months after that procedure. So despite the radioisotope decaying, the effect of the radiation lasts over time. And it's been approved for quite a long time in Canada. So it's kind of a similar diagram. We deliver those spheres into the tumor, and they sort of sit there and just emit this high dose of radiation. And in terms of the patient experience, it's outpatient as opposed to inpatient. There's a planning day where you come to hospital, we map everything out, we do test doses, but we're not doing anything to treat your liver that day. But we use all that information from the mapping day to prescribe the dose of radiation to bring you back. And that therapy day is usually a week or two later. We do a liver angiogram, but typically we sort of know what we're doing. I give analogies. If you're a handy person, you do all your planning, then that's the day to cut the wood. You go and you kind of know your plan and you know exactly what you're doing. You recover for a couple hours and go home. Similar risks, okay? Theoretically, the risk of liver infection is lower with Y90, but as we can see with Jason, it can definitely happen. But liver failure is something we worry about. But I would say in the neuroendocrine population, we don't worry as much. But I do worry because with a lower grade tumor, patients with neuroendocrine cancer are around longer. So we do use Y90 sparingly. We don't want to give you the complications of radiation fibrosis of the liver that all of a sudden now we've given you a new set of problems that you didn't want to have. So we don't want to use Y90 on everybody and use it, because we do have to be a bit cognizant of some of the complications. So side effects are fairly similar, but the big things I want to mention is we just have some precautions. If you were a dangerous society, we'd have to lock you up in the basement somewhere, but you're not. But we just give you some precautions to say, hey, avoid sleeping in the same bed as your partner and keeping a meter distance between people for a few days, and avoiding pregnant ladies and children and young children for 7 days. I also learned don't put pets on the lap. So if you got tiny pets, I had a patient whose cat got real sick. Found that one the hard way. I don't want to spend too long because I think I'm almost at my time limit, but the biggest thing I'd love to emphasize is the neuroendocrine team, having all these great experts in the room and really putting the patient at the center. And it's not really this or that, or, it's really a lot of times multiple different treatments and how to sequence them, but really having the right experts in the room and involving the patients in that discussion as well. We tend to really try to limit our treatments in IR to people with liver-only metastases or liver-predominant metastases in the lower grade cancers. If you have high-grade disease, it doesn't make sense to come see me, or people that have functional disease, because we do have a pretty good effect on patients with carcinoid syndrome. And that's kind of what we're aiming to do, right? We want to ideally prolong life. We want to prevent disease progression, and we want to improve symptoms. Maybe not. This is kind of our conclusion. No big thing difference from what I've already said. But at the end of the day, we want you guys to feel empowered to ask the tough questions of us. But you are, generally discussed in these multidisciplinary tumor boards. And if you do come to someone like myself, definitely hit them with the hard balls as to why they're there. But it still has a role to play, despite having good access to different therapies, including Lutathera. And in fact, we work very well in our team, even in patients that sometimes get both. So it's definitely something to think about. So hopefully this has been helpful for you guys, and we'll go from there.
Thank you, Dr. Mujoomdar. So definitely save all your questions. Our last speaker for this section, Dr. Rebecca Wong. She's a professor in the Department of Radiation Oncology at the University and the Director of Clinical Trials for Radiation Medicine at Princess Margaret. Her focus in this area is to use radiotherapy through clinical trials, knowledge synthesis, and guidelines development. She's an author for over 100 peer-reviewed publications and 8 book chapters. Dr. Wong, it's my privilege.
Good afternoon, everyone. I want to thank the organizing committee for the opportunity to be here. It's one of my favorite conferences to have the opportunity to interact with patients and caregivers. It should be Wong. I just have Cnets. Okay, peptide receptor radionuclide therapy, PRRT. I want to talk about current indications, sequencing and special considerations, and a glimpse into the future, touching upon some new clinical trials that are coming. So the PRRT story started over 30 years ago. On the picture on the right is a endocrine professor, Professor Cnets, who attended a graduate meeting and noticed the potential utility of somatostatin receptors as a target for therapy and diagnosis. It took 30-odd years for all the legwork to be done, the clinical evidence to be built, and ultimately the randomized trial that proved that it is beneficial to our patients and made a standard of care. Hopefully, the journey will be much faster and shorter with more innovations going forward, and in other cancers as well with this modality. So for patients and for the clinical system, it is a new endeavor. There are some people who have been working in this for many years, which is their bread and butter, but to scale it so that patients across the country and globally to have this treatment, it requires a lot of innovation, collaboration in cancer centers that perhaps is novel and breaking down silos. The important part of a radiopharmaceutical, different from other chemotherapy, radiation, surgery, is that each dose needs to be made for each patient. The drug has a half-life of 7 days, and therefore you can't really make a big batch and put it on the shelf. It has to be created. And the compounding facilities usually take about 9 to 12 months to get it up and running, to go through all the safety procedures and quality assurance before they can produce the drug. Once that is set up, then the physician orders the drug for each patient, and usually it requires a 2-week interval in advance to order this so that the drug is available on the appointed day. On the day when it is needed, the drug is shipped from the compounding pharmacy, radiopharmaceutical institute, and driven or flown to the hospital. And when it arrives, it also needs to go through radiation quality assurance and processes to make sure the quality is correct and the dose is what we expect. And then it gets moved to the patient's bedside where it's delivered to the patient. After the treatment has been delivered, we usually obtain a SPECT scan that allows us to see where the drug has been taken up, both in the tumor as well as in normal tissues. For centers who do individualized dosimetry, it requires maybe an extra scan in a few days' time to provide quantitative information as to how much dose has been absorbed by the tumor and by the normal structures. That's from the hospitals and the healthcare professionals' perspective. From the patient's perspective, after the decision has been made to deliver this treatment and the ordering took place, about a week before you're having treatment, there's usually a clinical assessment, make sure the condition hasn't changed, the blood work is checked again, and review of the radiation safety procedures that you want to have to follow after the injection has been given. On the day of the treatment, patients at our institution is expected to be there at around 7:30 in the morning. Suffice to say that you'll be at the treatment center for about 4 to 6 hours. When you have arrived, after it's settled down, 2 IVs are set up to allow the hydration, amino acid, and drug to be delivered. There are pre-medications to prevent nausea, and the infusion takes about 4 hours. During that time, the radiation safety procedures within the room to protect the caregivers that may be waiting for you, and the healthcare workers that are looking after you. Following that, the SPECT scan that I mentioned, basically no more injections required. It just picks up the radiation that is emitted by the drug to see where it's end up after it's been injected to you. After the treatment, the radiation safety procedures will be well ingrained and educated to you and your caregivers. And basically, it requires maintaining distance and having your own bed, bathroom, and avoiding young children and pregnant patients, pregnant caregivers within a 7-day period, after which one is able to go back to your normal activities. What sort of benefit do we anticipate? There have been lots of studies, single arm that has been done, but it's this randomized trial, NET-1, that provided the data that really solidified and gave us the gold standard at which to compare other treatments. Patients are randomized to receive lutetium-177 dotatate with modest dose of somatostatin analog versus higher dose of somatostatin analog. And we can see that there is benefit in quality of life, progression-free survival in the first and second graph that you're in front of you. For patients, quality of life, the time to progression, worsening of the quality of life is much longer at 29 months compared with 7 in the standard arm. The progression-free survival at 20 months was 65% compared with 11 months. The quality of life did not reach, the survival difference did not reach statistical significance. You can see the survival curve on the right that it parted at the earlier years but come together after 5 years. So those are the hard numbers that persuaded physicians as well as healthcare authorities to make this part of standard of care. First, the FDA provided approval back in 2018, endorsing it to be used for GEP-NET patients, gastrointestinal pancreatic neuroendocrine patients. In Canada, for a drug to be, a novel drug to be available to patients, they require Health Canada approval, which is equivalent to the FDA. Following that, there's an evaluation process that looks at the cost effectiveness and the impact to society. And the body that does that for Canada is PCODA, and is supported and relied upon by all the provinces except Quebec, which has its own system. So Health Canada provided approval back in 2019, again for GEP-NET patients, and PCODA, the Pan-Canadian Oncology Review Board provided recommendations to fund the drug for mid-GEP patients, which are the type of patients that was included in the NET trial, but not for the broader GEP-NET population. I'd also have some stipulations emphasizing the importance of having infrastructure to support the delivery of this treatment across Canada. Since then, a lot of centers have prepared itself to be able to deliver Lutathera, which is the marketed product. In general terms, you can summarize it by saying that all the provinces has endorsed it to be used for well-differentiated mid-GEP patients, except in Quebec, where pancreatic patients, GEP-NET patients, are, have a broader access to this drug. I've had some extracts here, Ottawa, Hamilton, and some provinces in Atlantic Canada, including Newfoundland and New Brunswick, as continuing with the negotiation and putting into infrastructure to bring the treatment closer to home to patients in these regions. More recently, there's also been a submission to PCODA asking for approval for pancreatic neuroendocrine patients. And in September of last year, PCODA provided its preliminary recommendations and recommended the drug to be available and reimbursed for pNET patients with some conditions listed. And based, to sum it up, these conditions that are asked for, again, the emphasis on the infrastructure to provide quality of care and also price reduction guided by the effectiveness ratio and compared to standard of care everolimus and sunitinib. So these negotiations are ongoing, and hopefully it will see approval and broaden access going forward. This is a capsule summary of the typical patient that will be receiving standard of care PRRT. Mid-gut patient that probably have had many years living with the disease, with well-differentiated tumor, low Ki67 index, who have been through somatostatin analog and had a stable disease, maybe adjusting the dose with more frequency, but now the disease has shown progression. There would be a gallium-68 PET scan that demonstrate that the patient's tumor overexpresses somatostatin receptors. And there's a requirement for a tumor board discussion that there's consensus that this is the right treatment. For this particular patient, she underwent 4 cycles of PRRT, and for majority of patients, we expect a stabilization of the disease and improvement of symptoms. Sequencing this treatment and selecting the right patient is a bit of an art right now, mainly because there's no high quality evidence to guide, and we hope to generate these going forward. And there are so many factors that are nuanced considerations. There are many professional guidelines group that have generated guidelines to help physicians. Here's a summary in one of the recent papers. In general terms, they all endorse the use of PRRT for mid-gut well-differentiated tumors. The SNMMI also raised the possibility of this being a new adjuvant therapy for patients who have unresectable primaries where surgery may be possible with downstaging. This quote I like, emphasizing in one of the recent papers, emphasizing the need for more data, and therefore clinical studies to produce them, and the multidisciplinary team, multidisciplinary tumor boards that bring together expertise to make the best decisions for our patients. So a few special considerations I want to touch upon. Can we predict who will benefit? These treatments are long. It can last for a better part, almost half a year from beginning to end. And toxicity considerations. The PET scan, in addition to other clinical factors, are the most obvious thing that we want to hang our hat on. Can we look at the PET scan or early responses from PET and tell who might benefit and perhaps change the treatment trajectory if they're unlikely to? The bottom line is they're hopeful hypotheses, but it still requires data to prove. Obviously, where a lesion is very hot, it means that it has a lot of somatostatin receptors, and theoretically, it will attract a lot of the drug there and therefore give high doses and deliver and kill the tumors there and improve the outcome. But it's not always the case. Sometimes in other diseases, we have shown that PET early responses after the first treatment can predict outcome. And in some of the work we've been doing, there's a correlation, but not strong enough for us to pick out patients who we should change strategy. Here's a patient that the uptake actually increased after the first cycle, and there was a dramatic response. And I can show you pictures for people who decrease and have a dramatic response. So ongoing work. Molecular signatures are also very promising. Dr. Baudet at the Memorial Sloan Kettering have done many years of work behind this and have provided data for 2 tests, the NET test and the PPQ. These are, the other term for these tests is a liquid biopsy. You take a blood sample and you look at the genetic hints within the cells, the blood tissue fragments, and be able to hint at or prognosticate whether the patients are going to do well or not. The middle panel shows an impressive differentiation of patients who do well versus those who don't, in patients who have a PPQ positive test represented in blue versus those who do not. The NET test is used for monitoring and similarly is strongly correlated with outcome. Now, these are novel tests. They're expensive, and there's no strong standardization of laboratories to perform them, but these are really promising and hopefully become part of our standard care going forward. I want to touch upon toxicity. Of the toxicity that we talk to our patients in the long term, there's renal, hematological, and a special case of mesenteric fibrosis. Renal toxicity is something that have worried investigators because the drug is excreted in the kidneys, and the kidneys are particularly sensitive to radiation. That's why during the treatment delivery, you get amino acid hydration to protect the kidneys. To such an extent that the Lutathera product monograph actually suggested patients who have a creatinine clearance of less than 40 not to receive this particular treatment. The Mete trial provided good data. It's randomized and comparing patients who get it and didn't get it. And you can see the top graph on the right, the creatinine clearance over a 5-year period after long-term follow-up really did not change significantly, suggesting that in patients who started off with good renal function going to this treatment really have very little renal toxicity to worry about. What about patients who have renal insufficiency going into the treatment? And the bottom panel shows one of the recent papers that described 33 patients with renal insufficiency, and basically about a quarter of the patients have a drop of their renal function by one category. And they also provide some estimate that the reduction in creatinine clearance in these patient population could be on average about 2.5% per year, providing some guidance as to how to select our patients. Delivering the risk of tumor-related, treatment-related myelodysplastic disease is a serious complication, even though it happens rarely. In this systematic review, including over 7,000 patients, it's estimated that the risk of developing treatment-related myelodysplastic syndromes and AML is about 2.6%. The interval to delivery ranges from 40 to 125 months, typically after about a year. So for patients who are young and is earlier on in the disease trajectory, that's something that I discuss more carefully with our patients prior to entering. Risk factors are difficult to identify, and here's a list there. Finally, I want to touch upon mesenteric disease, particularly in mesenteric small bowel neuroendocrine patients, and we've heard some of that already. There's caution and observation that following PRRT, perhaps there's an increased risk of this. And in a recent paper by Strasberg et al., about a quarter of their patients who have high risk of bowel obstruction develop bowel obstruction about 3 months, within 3 months of receiving PRRT. And the authors suggested the coverage of steroids as a strategy to reduce the risk. So there are lots of talks earlier about clinical trials, so this will be quick. There are 3 clinical trials that will be coming to Canada. You've already heard about the Actinium 225 study for retreatment. There's a lutetium 177 study that Simron has talked about as well. Both of these trials are looking at retreatment, so create additional options for our patients. And also the third trial, which is a StopNet study, which basically asks the question whether somatostatin receptors should be stopped or continued during PRRT. There are other trials that are global in nature, looking at different histologic primary sites, changing the frequency and modulating dose, and also more novel radioisotopes to deliver the payload. But the more exciting future, I think, it's combining it with targeted therapy, immunotherapy, radiation to further enhance the outcome possible with this exciting modality. So my take-home messages is that PRRT is now squarely part of standard of care and is generally available to patients across the country. And hopefully pNET patients will have access to this more easily as well. I also want to emphasize tumor board is particularly important in individualizing treatments, and clinical trial participation will allow us to find the answers to the questions that will allow us to refine the treatment options and improve patient outcomes. Thank you for your interest.
So we have time for some questions. I think the speakers can probably stay back, and Amanda will pass the mic.
I will run around. So we have a couple of questions online from our live stream. So maybe we start with one there and then a couple in the room. So I'd be interested in hearing about the use of NanoKnife for NETs patients. Where is it available? How do we get assessed? Is it something that's an option specifically for patients that are non-resectable?
So NanoKnife refers to a very specific vendor called, which is really IRE. I would not say it's widely available in Canada. I think I know at UHN they were doing some very specific studies, but not outside of America and really in HCC and in Saskatchewan as well. And they were looking at more kidney cancer. So I wouldn't say it's a therapy that's widely available. And honestly, with the treatment armamentarium that we have, you know, I don't know if I would be pushing for that either. You know, if something is, the reason we would use it in the liver is because it's something central, then I would consider another type of therapy, and we have lots of great therapies.
Thank you so much. Do we have any questions here in the room for any of our speakers?
It's a question for Dr. Wong. You mentioned that with PRRT, patients are allowed to leave that same day with, you know, some radiation safety precautions, you know, different beds, you know, no cat on your lap, that sort of thing. My understanding in days past was that PRRT patients got locked up in a lead room or something and, you know, had to stay in hospital. I mean, when did that change, or did it ever change?
Yeah, I think it's really the country's level of comfort when to release patients. Certainly I have been, I think Dr. Lately and Dr. Ryson probably delivered it much longer than me, but since I first started delivering it about 7 years ago, we have always done it as an outpatient procedure. So our basically a radiation safety officer estimate the dose after the drug has been delivered, and get approval from CNSC, the oversight body, that with this level, can we discharge our patients? And the answer was yes. So the other comment is that it means that the patient has to be able to get home. So for example, patients that come down from Thunder Bay to have treatment, we have to keep them for an extra day to protect the public. So it's outpatient, I think, for most centers across Canada.
Any other questions in the room for speakers from this panel? Perfect. Here. Didn't learn my lesson wearing heels yesterday.
Dr. Wong, I didn't hear anything, but do you usually continue with the sandostatin afterwards, or does it depend on the patient?
Great question. So the reason that the answer is it depends. The reason why the question should we stop it is because maybe these are blocking the receptors so that the drug can't attach to it as effectively. But the Mete trial routinely delivered the Lutathera together with the somatostatin analogs. So generally, when patients are on it for symptoms, I definitely will keep them on. But if patients progress on it, don't need it for symptoms, and I can spare them an injection, I have said to stop it. But hopefully the trials that will be coming would answer that as well.
I think it's a really good question, because
in the United States, the FDA mandates that people who get PRRT stay on the somatostatin analog, and as Dr. Wong was saying, that may be, excuse me, an extra injection. There's also a thought that maybe giving the injection blocks some of what we call the cold receptors, and so the PRRT can work more effectively at the opposite effects. We don't know, and that's what that trial that we had mentioned, the StopNet trial, which is going to be done in Canada, Australia, New Zealand, to answer that question if it's actually worthwhile continuing it or not.
I have a question for Dr. Singh, actually. So talking about the oral SSA trial, Dr. Singh, so have you already started the trial? The patients, have you seen any upper GI effects more so in those patients taking oral SSAs? And also, is there a time lag? Do you have to use more short acting in those functional patients while the oral takes its effect?
Yeah, so yeah, we have started the trial, and it would be too early to really talk about any results at this point. So far, no, I haven't seen any of those sort of things. Yes, so the idea would be that the trial includes an oral SSA with a backup, what we call rescue medication of the short-acting injectable, in case people, if they're still having symptoms, we don't want people obviously to be suffering. So then there's a rescue medication that can be given accordingly to help control symptoms.
Any other questions? So probably one last question for Dr. Simoneau, probably about the transplant, because that is an area which is like a rare patient that actually qualifies. In the criteria that you have shown, we did not note any stability. Different centers have different timelines as to how long they have to be stable before going on to the transplant list. Do they have to be of all systemic treatments, and is there timelines at your center for a patient to go on to a liver transplant for NETs?
It's a good question. We don't have a specific timelines, and I think in the protocol there is none, but historically, if you look at all the studies, the median time, from diagnosis to the transplant is almost 3 years. So it's usually patients that have gone through multiple lines of therapy, they have that disease, so they're already selected. And so I think like just by the selection of the patient who are going to be the best candidate, there are already some test of time that's being done, so it's not part of the protocol.
Thank you. I think we are taking 15 minutes break, and we'll be back. We're almost on time, but not quite. Safe travel.
They got a point. I know, but you like did in circles. I came up after Well, we're not as organized as that. Thank you. Oh, no. Yeah, it's a little bit. Yes.
Hi there. Just in the interest of time, we'll ask our actually panel members to, in the interest of time, we'll just get started with our panel by inviting our panel members to the stage. Dr. Del Rivero, Dr. Wong, Dr. Simoneau, Dr. Mujoomdar, Dr. Mete. I think Dr. Lateeg isn't here. Yeah. Dr. Law is going to start with the case presentation, and we have our panel ready.
All right, good afternoon. Oh, it's always good to be after the stretch than before when everyone's staring at you, waiting for you to finish. So over the next few minutes, I think we're just going to just ask about talking about some cases. I am so lucky to have this distinguished panel here to actually answer the questions. And I think what we're going to do is share with you some examples. Really, the purpose of this, I think, is just to watch us all discuss a clinical situation. I think that it helps illustrate many of the things that people have talked about, maybe in a more real case scenario. But this is a fake remote. I'm just waiting for this. Well, we can stay here while I chat and I figure out the remote thing. But there's a couple of things. Okay, so every time I do a case presentation for something like Cnets, there are some ground rules that I think are really reasonable. Okay, so first, very important, we are not here to create any paranoia or hypochondria. We're going to be talking about some things. I'm not going to bring easy cases that are, fairly familiar to everybody. We're going to talk about things that are a little bit more unfamiliar, but they're not meant to frighten you into anything. Second thing is you're going to have to forgive me because some of the cases are going to sound like you, all right? But they're probably not you at all. But we see a lot of patients and we have a lot of similar problems. They're all fairly complicated, but it's hard for us as physicians doing this kind of discussion at a very superficial level. Like we're going to talk about it at a level discussions, and even if the case sounds exactly like you, it may not apply to you at all. So I just want to, I'm not trying to we want to help you guys see what we do. We want to educate you. I just want to make sure that I don't turn it into something that becomes a fight with you and your doctor later, because dark and light spaces in here. There's something similar in the liver as well. And then here, a little further down, you can see it much more clear. This is not supposed to be there. This is supposed to be there. That's your colon. This is supposed to be there. That's your liver. This is supposed to be there. That's your spinal. That's your spinal column. Your spinal cord is right here. And these are the muscles in your body, on your back. So all of that's supposed to be there, but this isn't supposed to be there. And you can also see how close it is to this is a little bit of the spleen here. And that, again, demonstrates what Dr. Simoneau was talking about this morning. When it's really close to the spleen, you can't always separate it. So, thanks. So, that's just typically what we might see when you first come and see us. There's no real other details. So I thought this would be a reasonable point, except that the answers came through. So anyways, so much for the animation. But let's talk to our panel for a second. You saw that. What other imaging would you guys normally do? Well, start with Dr. Simoneau, because it usually starts with us as surgeons. We are lump and bump people. That's what we do. I can try to go back with, oh my God, it worked.
Hello? Yeah.
Oh, let's just start.
No, for this patient, typically on all pancreatic mass, we do EUS. So I think it's important to get a biopsy to grade this mass. And then because of the liver lesion, we'll either characterize it with MRI, but definitely do a TATE also.
Yeah. Yeah. So a lot of you are familiar with, I think, based on what I heard from today with that scan. But an EUS is a really good point. So we don't typically do biopsies from the outside for the pancreas anymore. I'm looking at Dr. Simoneau to make sure I'm saying the right thing. But the pancreas likes to make digestive enzymes, and it's better to keep it in the digestive system. And the stomach literally lies on top of your pancreas. Pancreas is actually pretty close to the back of your body, so it's nice to have experts that come in with a scope that can go down. There's a little tiny ultrasound at the end of the scope so they can actually see through the stomach. They're just using your stomach as an access point, and they can see through the pancreas and they can take it. This is the part that Dr. Mete loves, when we give him 2 or 3 cells and says, oh, Ozgur, can you tell us what this is? And the Ki67, which, by the way, I think, Ozgur, if I remember right, the original definition was number of cells proliferating out of 1,000. So he loves it when we just remember those little EUSs. You're working your pathologist pretty hard. And yes, a functional scan. This is going to be one of the first things we do. Dr. Simoneau, in case you didn't say it, we also wanted to get an MRI, partly because for the liver has unique signal characteristics, and the MRI can look at that. I know for our patients, and Dr. Yelamanchili and I share some, it feels like you get every test forever before anyone makes a decision, but there are actually reasons for each one. And the liver MRI, even though you had this area looked at, it's particularly important when you have that weird looking spot there. and you also have that weird looking spot in the pancreas. So we did do those tests. At the time, we didn't have 68 gallium, but we did have the octreotide scan, which is not as high resolution, but works in a similar way. It's looking for the same function. And what we ended up finding was that the pancreas was the only part that lit up on the octreotide scan. So that is the only part that has these somatostatin receptors in them. And what's really important for you is that liver lesion, even though it looks so similar, was actually a hemangioma. And what's really important is that it looks exactly the same on your first scan. Now, what's important for this gentleman is that if you assume this was metastatic, the options you'd be given are quite different. So it's really important that you had that. Now, you can also, of course, if you had a 68 gallium, similar to that octreotide scan, that area was also negative, but it's nice to have a bit of correlation. And we can, and hopefully some of these cases will explain why that correlation is important. Okay, so we decided for surgery. Would you agree with that, Dr. Simoneau? Yeah, so I think in the end, we felt if this is the only spot that lights up, the next thing you should have is to have this done. And at the time, this is all we really learned. It's an 11 centimeter pancreas neuroendocrine tumor. It was well differentiated. Ki67 was low. That's a grade 1, which is less than 3%. All the lymph nodes were negative. And then there is something called LVI-PNI, where they look at where the tumor is trying to infiltrate the lymphatics and the little nerves, and that was negative as well. Dr. Mete, do you have any thoughts? Like, what else would you have tested today? Like, this is a little bit dated, but anything else you do? There's a microphone beside you.
Okay, I think the basic is provided, but this is not enough, of course, in 2023. One of the things is I would have considered the less than 3% is, let's assume that this is correct, because the tumor will have, especially an 11 centimeter tumor, I will have difficulty to digest grade 1 diagnosis, to be honest. It doesn't mean that it doesn't exist. It may be correct, but I would have done in multiple tumor blocks, Ki67 assessment, to hunt for proliferative areas in the tumor. The second things I would have done a hormone immunohistochemistry to see what are the cell differentiation, because the more and more we understand, especially the epigenetic and methylome data clearly shows that some of the non-functional tumors with certain differentiation phenotypes, they do have different biologies, like alpha cell or beta cell like differentiation are totally different in terms of their epigenetic signatures. And similarly, menin or DAX-ATRX, these are some biomarkers that help us to narrow down some relatively more aggressive potential in well-differentiated neuroendocrine tumors. A part of it, I don't think I would have done anything beyond that, and I would have documented if there was anything in the non-tumorous pancreas, because it tells us so much information about why this 54 years old patient did get an 11 centimeter neuroendocrine neoplasm, and especially in epithelial well-differentiated or NET diagnosis. So it doesn't form in one day, and why this is happening.
Yeah, we agree. Like, now you look back at the case and you think, this is really interesting. It's well differentiated, low grade, yet it's big, which is kind of a head scratcher because he's not that old. So it didn't take that long to grow. So let me bug you a little bit more. One thing that's hard for you guys is that you're asking a pathologist to look at this big round ball that you took out. It's not easy when you're looking at little slices on a glass slide, unless, Oscar, you can read 300 slides a minute. How are you gonna understand what's going on? Like you said, you check other parts of the tumor. Is there a technique that you might want to share as to how to get the best representation?
So for tumors that are up to 4 centimeter, 4 to 5 centimeter, I think submissions of the entire tumor is an easy process for us to process the tumor tissue. But most laboratories will not submit your 11 centimeter tumors in toto unless you are dealing with a pathologist that is more obsessive compulsive like me. I may be requesting the entire tumor to be submitted. And there are logics behind of it. But let's assume that at least one section per centimeter is submitted. So at least we will have 11 sections from the tumor, and also at margins and other non-tumorous areas that it's adding up. So I don't think this is that much difficult to assess a specimen like this, but a good workup of a pancreatectomy specimen will take easily 3 to 4 hours and a couple of cycles, because we need to order some tests, wait for the laboratory to proceed with the staining or for the assessments, and then after we will receive them and we will consolidate all these findings. So I don't think it's a difficult process, but it's time demanding. This is why we do spend lots of time that you as a patient are not aware of it. Sometimes I work 12, 13 hours per day to make sure that I do deliver the reports in a timely manner, and sometimes on the weekend too, to capture whatever I can do for that week. So it's a labor intense work, which is usually unrecognized in my opinion.
Noted. Short plug for you. I mean, I know our patients, all want the path report, like literally after we finish the operation. I think work with your surgeons like Dr. Simoneau and I, just get yourself better, heal up over the next 3 weeks, and then give Dr. Mete lots of time. You want them to take more time, actually. You don't want them to take one section and be done with it. There you go. So so here's the good news, which is sort of what we expected, that he's out camping at 5 years. And I wanted to, Rebecca, why don't I ask you, when do we stop following up people with this? It's a trap, just so you know, like they said in Star Wars. No, I'm just kidding. No, Dr. Wong. Oh, yeah, I didn't involve you earlier, so I have to throw something at you. Sorry, we could hear you.
Yeah, I think these patients are at risk for late recurrences, and sometimes there are genetic predispositions. I would continue to follow the patient.
Yeah, I think we all debate, like, honestly, I wrote 5 years because, well, this was happening at 5 years, but it's also the number that you'll hear a lot for most cancer treatment follow-ups, right? Like most of our other things that we do, we kind of say the magic number is 5. But let me ask the panel, is there any feeling, I have a feeling in our group is we're trying to push it out a little further, maybe 10, and even then maybe it's like see you every couple of years. Is that, anybody else want to comment on that?
So the frequency may be less at some point if they're completely disease-free, but because you also don't want some coming back for every 6-month CAT scan, and then once a year nuclear medicine, which was kind of what we were doing for a long time. But you don't want to also say go on and never come back. Yeah, patients come back.
That's also important. If you're here with us a long time, we're happy for you. But if we turn you into a glowing egg on the next Halloween, it's not good either. So you got to find a balance. And of course, like I said, it's a bit of a trap. As you can imagine, at year 7, when we weren't following him anymore at that time, he had a brief bout of abdominal pain during a vacation. Ultrasound says, well, maybe there's something really small. I'm actually not sure how they saw that on ultrasound. It was really tiny, so it must have been a lucky hit. The pain was pretty thin too. And then, at that time he felt great. Like there was nothing. He had a major family event. He said, let's just see me next year. We don't know what it is at 9 millimeters, but it's a little bit of a problem when a year later it comes back and it's about 19 millimeters. So it's convincingly growing. Dr. Yelamanchili, any thoughts if they came back to you?
Yeah, I do have some of these patients because they have surgeries with Dr. Law, and sometimes I do the follow-up. So I have some of
Whoops,
these.
I didn't mean to set that up.
No, that is called shared care, right? And because I can't do the surgery and I can do the follow-up closer to home, that's exactly what we should be doing. So yeah, when we see that the rate of growth from 9 to 19 millimeters doesn't usually represent a grade 1. So I have my doubts. So number 1, establish the extent of disease. So we re-image him with the proper imaging, multiphasic contrast, CT, MRI, depending upon what we see in the liver, and if possible, depending upon what you find, the gallium dotate at that point. But based on the imaging findings, I probably would also consider a rebiopsy because I'm not sure that I believe the Ki-67 of less than 3% at this point.
Okay. Any other thoughts from the panel in the meantime? Well, there's one way of biopsying. That would be to take it out. I think at this point, all jokes aside, he was pretty upset at himself, to be honest, that he waited this long. And we didn't just because we don't have all day. That's why I said we were a little superficial, but we imaged him again. We octreotide scanned him again. It was only one spot. We said, okay, let's do what we can. And given that it's only in this, we offered another operation, which is never easy because everything's different after the first operation, but he managed to get this out. Now things look a little different. So I'm gonna ask, I'm already in trouble since the path report's wrong.
So I think before I think this pathology report is not giving you what's going on.
Yeah.
Number one, is this the recurrence of the former tumor? Or is this a new second primary? That's very essentially important. And 50 years old patient can easily have a germline pathogenic variant leading to multifocal disease. That's why maybe this tumor is biologically, to start with, is a distinct clone. Maybe the patient had an 11 centimeter grade 1 disease, but this may not be related to the former tumor. And this can still be coming from somewhere else, because especially if this patient has a germline disease, this tumor may be a spread from somewhere else. So this pathology report doesn't tell me if this is from pancreas or if it is related to the former. We need to understand that multifocality is very important in pancreatic neuroendocrine neoplasia. And now the most recent data suggested 1 in 4 patients, 25% of the pancreatic neuroendocrine tumors are related to germline susceptibility syndromes with no familial history in most of the time.
It's a perfect segue to Dr. Del Rivero. Any thoughts on that from a clinical point of view? That's when everyone offers you the microphone at the same time.
Yes, I do agree with every comment about initially when he was presented with an 11 centimeter mass. It seems like there was some cystic component, if I can see on the prior scan. The fact that there is another tumor, I do agree that one of the things that needs to come in mind, especially in a 54-year-old male, is, as discussed previously, whether we're thinking about the cancer predisposition syndrome associated with neuroendocrine tumors, whether it's MEN1 or VHL in that sense. One thing just to mention as well is about when to do hormonal evaluation, and just kind of putting my endocrine hat here, because we're talking about the pancreas neuroendocrine tumors. Yeah. And based on what the, some reports said, it could be up to 10% in Europe, it could be up to 30% of patients with pancreas neuroendocrine tumor may secrete that hormone, and that hormone or peptide can cause symptoms. And usually we know if there is a hormone that is secreted by the pancreas neuroendocrine tumors, we usually know based on the symptoms. And earlier today, they had a very nice review of the functional pancreas neuroendocrine tumors producing symptoms. And the question is sometimes like, do we do hormonal evaluation? And that's something that we're trying to figure out. It seems that some providers may do a whole hormonal evaluation. Me personally, I just do a hormonal evaluation if there are symptoms related to the or associated with the pancreas neuroendocrine tumors. In this case, the only symptom that the patient had was a left upper quadrant. It seems no other symptoms associated with that. I don't think a further hormonal evaluation is needed, but I do definitely will send the patient to a genetic counselor just to make sure that we're not missing any other cancer predisposition syndrome.
Yeah, I think that's very good advice for everybody who goes through that. Now, before Oscar completely destroys me more, I'm not going. This is from a while ago, and you'll see in a second. And but let me just fill in 1 second. So we did, like, we as a team were starting to get worried. Okay, number one is the Ki67 is now G2, so it's a little different. You can tell we can't get as much lymph nodes as last time because everything's all scarred in. It's just not that easy. It's behaving a little different with this comment about lymphovascular invasion. Everything just looked different. So Dr. Dover, we did send him genetics clinic. Apparently he didn't test positive for any known mutations. That doesn't mean you don't have one. It's just whatever we had the test at the time. Oscar, we didn't have the other technology look more at his liver yet, but here, go back to you.
So one thing to expand on germline testing, I think we have to understand the limitations of the current approach. And usually medical geneticists explain this clearly to patients and their caregivers, but you have to understand, we use certain panels approach with certain NGS technologies to screen for the most common, well-known germline pathogenic variant. Most of these patients, in fact, don't have the well-known syndrome. Instead, they have other isolated DNA repair germline alterations. Either this patient's family had a breast cancer, it can be related to one of these MUT mutations or BRCA mutations, CHEK2 mutations. We do see more and more frequently in this population. Therefore, we should certainly consider having if this represents a second tumor, I want this patient's blood to be assessed for whole exome or whole genome sequencing to find an answer. Because there's beyond this patient, his or her relatives and all these loved ones who might be at risk of developing other endocrine or non-neuroendocrine tumors.
Okay. Well, things do get interesting because we follow much more closely. Now we're at year 9. And now there's a left lung lesion that was small, not seen before. And there are a whole bunch of lymph nodes which are a little bit bigger than they used to be. They're not huge. They're about 1.8 centimeters. So he gets another functional scan. He still didn't have we still didn't have 68 gallium at the time. And he's got uptake in the nodes in the left lung. So the areas that we saw in the CT. So we fortunately didn't see anything else, although we now know that octreotide is a little bit more limited. What would we do now? You want to take it? Like, what do we do with him? He feels fine. He's recovered from a second surgery. These are very low volume, but definitely positive now.
Looking at the extent of the disease, of course, it doesn't look resectable, but I'll ask my surgeons to make sure that there is no resectability there, although I'd be leery about resection given the disease biology and the natural history in the last few years. So then we think about he's asymptomatic, but the rate of growth warrants some sort of treatment. So this is not a situation where we'll be doing expectant management, even though he's asymptomatic. So we'd be discussing systemic treatments. If it was as of today, he'd be a candidate for Sorrento trial.
Yeah.
So obviously back then, so we would be considering everolimus as one of the options, targeted agents. There was, of course, and even KS of 10%, even SSA would not be a bad option. So we'll discuss everolimus versus lanreotide. Both would be options, depending upon the side effects, what we prefer, and also the extent of the disease and the quality of life that the patient would want to, the goals for the patient.
And move to Quebec so that your pNET can be treated with PRRT. Nothing to remember.
I actually want to ask a question to
Yeah.
our pathology friends here, because we're talking about now a left lung lesion.
Yeah.
Right.
You were not here this morning,
Yeah.
So keratin immunohistochemistry will be very essential. This is a suspicious manifestation to me that is a missed paraganglioma, HDH deficient, and the precaval so-called lymph node might be another paraganglioma. Lung might be either met or primary disease. So we are opening a box right now where the keratin immunohistochemistry was I tried to elude it this morning. Epithelial and non-epithelial neuroendocrine neoplasms are totally distinct animals. And their biology are also totally different. So G1 type of lesions can easily be a primary pancreatic paraganglioma. So if we know that this is keratin positive, I would like to know if the lung lesion represent any met or primary tumor, because we have biomarkers to confirm where the cells are coming from. And it's not that difficult, or it doesn't take too much time to confirm this. If this patient has primary lung, so it's a different therapeutic approach, this is going to dictate a different therapeutic and management options for this patient.
All right.
So it seems like in this case, before making for recommendations, you will want to biopsy.
Make a decision how many tumors this patient has in terms of their site of origin.
And so this actually brings up a good point in that this is another thing hard for your doctors. around this time, I think Richard Hatch was winning Survivor, so that's a while ago. And Richard Hatch doesn't know how to spell keratin, I can tell you that. So the issue is that the ground changes under our feet a lot. And you know, I'd hope in the near future, Dr. Wong, that we could give PRRT for somebody like this, or as one of their future options, but we didn't have those options. And I think, Dr. Yelamanchili, you always know what I'm going to say. But anyways, he did get every option that we could think of up to that point, including everolimus and Sutent. And now we're in year 14. I know Oscar's probably writhing, wondering where all these specimens are gone. But he, you know, he's a very active guy. He's feeling reasonably well. He's getting treatment. And you know, when you have little interval growth, so this was another 5 years of growth, you know, things just kind of creep up on you. And at this point, he had this, which he was quite symptomatic from, and it was still thought to be the same. It still had octreotide avidity, but like those were the nodes that are no longer 1.8 centimeters. These are much bigger, and they're symptomatic on the right side at this point. He's just now on, I think at this point he was on 60 Q 14 days, so it's pretty higher dose of the sandostatin that we used more than. Would this be something nowadays that you could treat with PRRT, or would you want something else done first, Dr. Wong? I mean, he clearly has disease elsewhere. Just this was what was really bothering him.
It's very interesting. I think that it depends on one question I would ask is how quickly this is growing in the recent past, and whether there's any transformation. So a biopsy might be worthwhile. A repeat gallium scan to see if there's heterogeneity of uptake, plus or minus FDG, would help to confirm that it is not transformed if there is disease elsewhere. I think that if there are no other systemic options as not transformed, I think PRRT should be considered. It's not currently funded unless you're in Quebec, but the single arm series in pancreas show that the response rate is very similar to mid-gut patients. So I think it's clinically, it's definitely a worthwhile consideration.
Yeah.
So based on that mass, which is quite large, I
really
was
large.
and he's symptomatic from that mass. I was just wanting to ask my surgeons, what were your thoughts of resecting the mass based on the presentation, despite that we may have disease elsewhere, but he's having symptoms for that, and knowing that, so what were your thoughts?
No, definitely. I mean, like we don't have the full scan there, but I think if it's the mass debulking for symptoms is definitely a reasonable approach, even if you have disease elsewhere. You know, as long as the patient is medically fit and it makes sense in terms of comorbidities or. But yeah, definitely, it could be a good option.
Yeah, we really struggled with this, but it was really the only symptomatic area. I was trying to avoid all eye contact at tumor board, but as some of you know, Dr. Singh is the most aggressive surgeon on our tumor board. So pushing really hard for surgery, partly because, maybe back to you, Dr. Wong, they just didn't feel that any other therapy that could control it would actually shrink it and give them symptomatic relief. So the other areas, weirdly enough, were not really changing that much, and we're under good, what we would consider reasonable control with these somatostatin analogs. So there was a bit of a push to do this. So thank God you said that, Dr. Del Rivero, because we did take it out, and it felt so much better afterwards. But guys, you know, I just want to, in all humbleness, as surgeons, like I'm sure Dr. Simoneau agrees, I would never agree to do this without a plan. Like I need all the rest of you. Like I'm not just going to just take this out in isolation. Like it's not going to solve all the problems, and unless I didn't have all my other colleagues backing us up with other things that they're going to do for the other stuff, it wouldn't have made sense. But they did have some ideas, and we went onward with this, and it's amazing how some people can recover. Not everyone recovers easily, but he did, so that's another thing to consider. This is not always a walk in the park, and it was fairly large. It's grown 10 times its size in the 5 years, and Oscar's probably writhing right now because they still didn't tell us much, and I know this is not the same tumor, but anyways, because it's not behaving weirdly. But just so that we can get to the next case, I'm going to push it a little later. Like this is what his surgery looked like. That was before, that was right after. So there's, well, now everyone's looking on this side. So then I don't know, here, this is the kidney now. That's not a mass. So this thing is gone. So again, that's the kidney, that was the mass. And so everything's kind of gone back to where it's supposed to be. And the crazy part is, to put it in perspective, is he's now 75. We met at 54. As with many men in this room, we also gain metastatic prostate cancer as we go. So that's another thing he's dealing with, but he's having an excellent quality of life. And for whatever reason, after getting rid of those spots, Ozgur, the other spots have continued to just stay with the Sando. So we haven't moved on that. And he's getting other therapy for the prostate cancer, but this has been one of the cases that we really had to work on as a team. But it's really bizarre. But I think there's more than one thing going on, don't you think? There's got to be more than one tumor. So another thing that we always struggle with, that maybe we'll get to in the next case, is these imaging that we're doing is starting to help us understand a little bit about the biology. Okay, so next, this is the last one, then I think we'll just cut it off here. But I just wanted to bring up a few points here. This is a otherwise healthy, woman before, but the diarrhea was just out of control. And it wasn't from that trip from Mexico, because it was 6 years ago now. So there was a problem. It wasn't something she ate. It wasn't something she picked up. The issue with some of these people is they keep getting colonoscopies because they think it's a functional problem, because they look great. Otherwise, looking great is sometimes your worst enemy. But eventually a scan was performed, and that was an obvious problem. So I'm just going to let Dr. Simoneau comment a little bit, because these always go to the surgeons first. But we've got I tried to get the most representative picture for you to comment on, Dr. Simoneau, but we've got some problems here.
Yeah, I mean, the problem is there's an arrow, there's definitely nodal mass that's encasing the mesenteric vessel. So these are the vessels I was talking about that are draining the entire small bowel, and that eventually become the portal vein, which is the main blood supply to the liver. So that the white thing is being interrupted by this light gray mass. So that's probably nodal mass. There's also the stomach, which is, can you point there? Yep, it's definitely larger than usual. So that means that there's a blockage lower down, and also the small bowel is also like dilated as well, with fluid kind of sitting there. And there's also liver lesion.
Now, there's a lot of fluid, partly because we did an enterogram here. So what happens with an enterogram is we make you drink awful stuff, and then that's how we make them mad at radiologists. Dr. Mujoomdar, I say I didn't know what the contrast was, but I knew actually it was PrEP. And it's the same thing you take for colonoscopy. So if you have the runs after this particular test, there's a reason. But as a surgeon, we were really worried because, Dr. Simoneau, this is what always bothers us. We'd love to try and do our best to help all our patients cut it out. But when you've lost your circulation, or this tumor is completely encasing this, if we take this out, you got no blood flow in your digestive system, and you can't live without one. So now that's a problem. The other thing is the liver. It's hard to show you, but it's quite extensive. It wouldn't have been easy to take all of these out. And so now we start bugging Dr. Mujoomdar for ideas. You were talking about some embolizations or chemoembolizations, but is it safe to do that in a situation where the blood vessels downstream are blocked? Is there anything that you think of?
As long as the blood flow to the liver is preserved in terms of that big, maybe point out that nice juicy portal vein, then I think we're probably safe to go ahead with a liver-directed therapy. And as I mentioned, usually the liver-directed therapies tend to be good for people with the functional syndromes. Before we went there, and the CAT scan looks good, we'd also want to probably evaluate the heart, right? Because with this diagnosis, they can have, a carcinoid effect on the valves, and that will affect what I do, because if the valve disease, because we're picking somebody up at their presentation, they might already have valve disease, they might already be in some form of right heart failure maybe, and we don't see any evidence of that, at least on the CAT scan, but a CAT scan is just one test, right? They would need other tests to look at that, and that would affect. And it would actually affect, if Dr. Simoneau or Dr. Law want to lop out parts of that liver, then it becomes a whole, figuring out who's working first, and usually the heart wins, because obviously you need a good functioning heart to do the other aggressive therapies. But we would probably attack this with in my institution, probably be TACE. I'd maybe even consider Y90 if I can get really if it's just those 2 liver tumors, probably not just those 2 liver tumors, but probably a TACE or a blind embolization would be fine too.
Yeah. So we didn't do Y90 yet because we still hadn't approval for that yet. But and the echocardiogram, believe it or not, was normal. So then we did a few more tests, which I would say, given how bad the diarrhea was, I think our surgical preference, I don't know what Dr. Simoneau thinks, is we'd rather you get a little bit of control first. I don't really want to go in operating on you when you've got a full-on carcinoid syndrome going on. And it didn't surprise us that the 24-hour urinary 5-HI was like 720 micromole per day. So the normal should be like 45 or so. And so that's really, really high. And then they did get functional imaging, which basically showed avidity, which is this pickup signal through the liver, through the mesentery. No small bowel lesion was seen, even on that enterogram. But I think that when we biopsied it, with it having, I know Ozgur, sorry, my friend, I put the most limited details. He's like, there's so much more you could say, but that's all I got. But it did show a Ki-67 of 7% and a CDX2 that was positive. I hear you. Good pathology. I love it. I just fetch tissue for you, man. That's my own job. Okay. So I don't know what would the panelists do here? Anybody want to take a crack at what to do next? No, nothing. This is she's just in. I'm just sort of stretching out that we tried to do all of this as quick as we could, but so now we got to figure out what to do.
I mean, I would definitely consider, I think right now the priority is going to be, if they're not in bowel obstruction, the priority is going to be
they're not
disease in the liver. So I would get them in for an urgent liver procedure. I'd want to make sure they're well treated to prevent any carcinoid syndrome, because that's something we do worry about. And somebody who's quite symptomatic carcinoid, we don't want them to have a reaction on the table, which can happen. So whether we do that with a little bit of an injection before the procedure or putting them on an IV infusion, and to, aggressively treat their liver metastases in a sequential fashion to get their symptoms under control.
I will say she's charming, this patient, and I asked about bowel obstruction. She said, would that get rid of the diarrhea? At which point I thought, okay, maybe she doesn't have bowel obstruction. But anyways, so she definitely didn't. Had no symptoms of bowel obstruction whatsoever, like zero. Eating fine, everything was coming out. Anything? So you were just talking about putting her on short acting or something, but would anyone start her on anything? Yeah, sorry. Let's ask our medical oncologist. Yeah, please.
Sure. So I think one thing I wanted to ask is, did she lose any weight with all the diarrhea?
Yeah, she was always thin. So, but she was really thin.
Right.
Yeah.
So I think definitely we have enough to start our somatostatin analogs, both for symptom control. And with the Ki-67, she's where we probably could get some cytostatic effect as well. So I would start the long-acting somatostatin analogs, and then make sure her nutrition status is up to the mark. So a dietitian referral, and see what the issues with the diet, and optimize her nutrition status as well before you guys take her to the OR.
Oh, don't worry, there was no OR plan yet. Just making sure Dr. Simoneau didn't think, what? That definitely got her attention. No, there was no plan yet. We just wanted to get her syndrome under control. Dr. De Rivero?
Yes, yes, correct. So we're talking about a patient with a small bowel neuroendocrine tumors with liver mets, symptomatic from the excess of hormones. And yes, I think when we see that, one of the first things that we need to do is definitely control the symptoms. And long-acting somatostatin agonist, either lanreotide or sandostatin, is recommended. Sometimes your acne is needed, especially for some symptoms that are not under control. That said, I do agree that in some patients, liver-directed therapy can definitely control the symptoms more rapidly. But I do have a question for the intervention radiologist here, because he discussed earlier about the Y90, which is a type of radioembolization. And I think it's important, I think, for our patients to understand. And you just explained very nicely about the different type of embolization, whether it's bland embolization, radioembolization. At our institution, we do bland embolization. We sometimes don't do radioembolization, especially if we think that patients may need, if we feel like Lutathera can be an option later on, because we want to preserve as much as liver healthy liver as we can, and radioembolization sometimes can cause scar tissue, but at the same time, that's also up to the experience of the intervention radiologist. That's why in our institution, we're experts on blood embolization, but maybe that, if it is okay, could.
You know, we have a very long history at my institution with radioisotherapy. I think since the either late 90s, early 2000s, it was indium octreotide for a long time, I-131 MIBG, and then Lutathera. We were one of the early adopters. And at least anecdotally, I don't have data to answer your question, but anecdotally we have, because the radiation associated with Lutathera is not, it's not as high. Like, so I can only recall one patient that I've ever seen like liver toxicity, or what we call a radiation liver disease related to lutetium. I have not really seen that. Whereas in Y90, that is a real possibility. And for sure, I completely agree that this would not be our first line therapy in a patient to jump to Y90. We would jump to bland or chemoembolization, but we haven't seen that. And people have asked that question. So I think if they've had prior Lutathera, I would still treat, if they were a candidate for Y90, I would still treat them for that. And I think vice versa, depending on what we're treating. But so I don't think that we wouldn't factor that in.
Okay, I gotta speed this up a little bit because I just want to get us forward. We did do this sometime. So I mean, the contrast from the first case where we went right heavy with surgery first, this was quite different. Doesn't always work out that easily. Dr. Mujoomdar, I'm sure, I don't know if that's happened to you, but boy, we gave her the embolization after we started SSA, and she went into total renal failure, developed ascites, looked worse than she started. That really freaked us out. And it's certainly nothing that we intended to do. We had to really wait a long time, and with a lot of resuscitation, a lot of in-hospital stay just to get her better. And now we were like, okay, we dropped the 5HI a bit. It went from the 740 down to about 400, which we were happy with, but we weren't happy with her condition. She just didn't like it at all. I don't know what happened.
So do we know why she developed?
No, never did.
Do we think it's like contrast related, or was she not kind of, because of that prolonged diarrhea, was she a little bit more medically fragile leading up to the therapy, or I assume?
Actually, you bring up an interesting point, because it affects our other patients that have contrast allergies. So are you able to give embolization if you have a contrast allergy, like a really severe one?
Yeah, we would just aggressively treat with steroids in advance and really limit the amount. Or, I mean, there are some alternatives, but we don't really use them that often. Yeah, I mean, that is terrible and unfortunate. I mean, I do try. I was talking about this with one of our speakers from earlier today. I do try to selectively treat patients as much as possible, partly because you don't want to be overly aggressive in the liver and go too, embolized. Yeah, I won't even do the whole right lobe. I'll sort of really parcel it out just to make the recoveries better and hopefully try to prevent some of this.
I mean, it killed some of the tumor, but you can see there's still this little area still alive no matter what you do. So anyways, we felt that we should just leave her on SSA for a while. And then after a couple of years, she's still, now we got the 68 gallium. Now we redid it, but because she was acting so weirdly and because of all these other things, look, Ozgur, we're getting more modern. We did a dual, she qualified for the pNET. So she had both, and she had signal uptake with both gallium and 18-FDG, which means now, similar to that first patient when I was asking, it's not just one tumor. Ozgur, do you think, and we didn't have a biopsy, but I think this shows you why you need to look through the whole tumor, does it? Yeah. The other problem was that although her initial echo was normal, 2 years into this, another echo showed a severely dilated RV and tricuspid heart disease. Now, either we missed it or it was brewing. I've never seen anybody develop it this quickly, but she just kept running away from us with all these problems. Now, just moving forward, the good news was that eventually we got her settled. Dr. Wong, I'm going to give you some time to talk about this, but we basically begged Stan wherever he went, even followed him in the bathroom to get her PRRT, because our worry was that another embolization, we were a little worried about what happened last time, and she did still have some 68 gallium uptake, and we thought maybe we could treat that. Was that reasonable to ask him? We did get her renal function back, by the way, which was really amazing. Yeah, she went like a creatinine of 300 and it's back to like about 80, 97. Right.
I agree. I think somewhere along that lines, I would want to give PRRT. when you have both FDG and gallium scans, when they are concordant, it's not as, they still respond. It's when it's discordant that you should hold off, because they're high-grade components that it's going to drive the disease process. So yeah, I agree.
Yeah. So crazy enough is that in order to treat that liver, because we still couldn't get her 5-HI down, the diarrhea was really bad. Dr. Mujoomdar, we were maybe a little crazy enough to think about Tara and gave her a dose of it, and seemed to help a little bit more actually. But it was one thing, maybe you can talk about it more, but one thing that our interventional radiologist told us is, remember, it's not embolic. So maybe you want to expand on that, people can understand.
It's so microscopic. You're just a vehicle to deliver radiation into the tumor. You're not blocking things off. And in fact, you want blood flow to be there. That's the whole basis of Dr. Wong's specialty, right? Is we need oxygen, right? We need blood flow to the tumor. It would be nonsensical for me to deliver the radiation and then block off the blood vessel. So yeah, they're too tiny to cause any embolization. So radioembolization is actually a terrible word for it. It's not. It's internal radiation therapy.
So I'm going to end here because we're way over time, but I hope those cases show you just how complicated it is. I do want to emphasize that, you know, we a lot of your physicians, we really care about you. We really fight with each other for your treatment, but it's not easy treatment. I will say she's doing great now, but boy, that was one hard way to go. So, and still no surgery. Dr. Simoneau, still no surgery.
All hands on deck.
All hands on deck.
Can I just add that individual doing dosimetry would be helpful for these patients going forward. We don't know exactly what to do with that information, but be able to quantify the dose received through PRRT, received through radioembolization, and in some patients they get external beam radiotherapy. All of them add up, and if we can quantify it, it will guide decision making.
Yeah, that's going to help us in the future for sure. Okay, thank you to all my colleagues for a great discussion.
Thank you, Dr. La. Very thought-provoking cases and done very well. Thank you. I thank the panel as well for participation. And thank you, everybody, for sticking out to the last leg. I do want to mention that Dr. Pasika's talk is actually virtual, so it's a video recording. So we are going to skip that here, and we'll post that video on the Cnets so that you guys can get to it at your own time. So that will save us some time, and we can all get home at a proper time. So the next speaker is Net Nutrition in the supportive care section. Lindsay Lee is a registered dietitian with the Alberta Health Sciences. I would request her to come on for our next session.
I'm getting out a timer so that we can, let you go home at some point. All right, well, it's a pleasure to be here with you today, and thank you to Cnets for inviting me. I'm Lindsay Lee. I work at the Cross Cancer Institute in Edmonton, Alberta. It's nice to escape the wildfire smoke and be here for a little nice fresh air. So I'm enjoying seeing the city, and getting to meet with all you folks in person is great. It's been a while. So thank you so much for sticking to the end. We are going to talk today very briefly about nutrition. And I think it's an area that we need to pay attention to. As was mentioned in the last presentation, if you're going to go through all these treatments well, you need to have a good baseline, right? And you need to have a good ability to be able to withstand those treatments. And nutrition is kind of the baseline of that, having a good foundation. So we're going to go through all of this in brief. In case I forget to say it at the end, I would just strongly encourage you to seek out a dietitian on your local team. This is a very complicated disease, and we all need to work together, and we need to make sure that we have good communication between surgeons, between your medical oncologist, between your dietitian, so that we can make the most appropriate care for you. So we know that malnutrition is a common concern among all types of cancer patients, and unfortunately, the neuroendocrine population is a much under-researched area in terms of nutrition. Lots of reasons for that, lots of challenges there, but I think often when we look at the nutrition research that does exist with NETs, we have a hard time finding different parts of the population. They're kind of all lumped together, right? So if we're looking at patients that have serotonin producing tumors and insulinomas and glucanomas, we're not going to treat that all the same with your diet. It's going to be very different. So trying to take all of that research and put it just in the category of nutrition is not always helpful, and it's very challenging. But we do have some evidence, and so I'm going to present what we do have today. And we know that malnutrition is probably an under-recognized condition in the NET population. And like many things, there's no set consensus on definitions of some of these terms. But for malnutrition, as stated by Espen, it's a state resulting from lack of intake or uptake of nutrition that leads to altered body composition, often meaning loss of muscle tissue or lean tissue. And that leads to diminished physical and mental function and really impaired clinical outcome from disease. So it impacts outcomes from some of these other treatments. Now, we know that this nutrition risk or this malnutrition can be impacted by the way the tumor is behaving. So what is the tumor secreting? What kind of hormones are we dealing with? What kind of syndromes? As well as the surgeries themselves. You know, if you've had an intestinal surgery, if you've had any of your bowels resected or removed, that's going to have implications for your diet and for your nutrition. So we need to take that into account for sure. As well as some of our other treatments, including the somatostatin analogs that are so common as first-line treatments, that can have an impact on your diet and your absorption of nutrients. So probably the top question that I get asked as a dietitian is, what do I have to avoid? And kind of a pet peeve of mine, because as a dietitian, I want you to include as much food as possible. I want you to have variety in your diet. We want you to make sure you're not missing out on any nutrients. So as dietitians, we're really not interested in any fad diets. So please don't go to Dr. Google. Let's try and find some reputable sources for our information. There are no hard and fast rules for a diet for neuroendocrine tumors. There's no one size fits all. They're all very unique. Your symptoms are going to be unique, your challenges. So we want to recognize that. As well, we don't want to unnecessarily cut out foods. So I'm going to go through a list of some of the top 10 foods that might be foods to approach with caution, but this may not apply to you. And if this food is not problematic for you, please don't eliminate it from your diet if there's no reason to do so. So first of all, spicy foods. And again, this is not based on robust evidence, unfortunately. There are not a lot of randomized controlled trials or the gold standard of research here. A lot of this is based on large population surveys that were done starting in 2000 and 2008. And so spicy foods tend to be problematic. This more so with serotonin producing type of tumors. And the top symptom that they seem to exacerbate was the flushing. Similarly with alcohol and caffeine reported to be problematic and to exacerbate flushing. So this survey was focused on the classical carcinoid symptoms, right? So looking for patients' reports of flushing, bloating, diarrhea, rapid or increased heartbeat, shortness of breath. So those classical carcinoid symptoms, which again, does not apply to every person. High fiber foods can be problematic for some. And this would be more so, I would argue, in those that are having diarrhea, right? So you're having digestive symptoms or digestive issues. We're going to talk more about that. As well, high fat meals, but again, this is not going to be across the board. I would argue that this would be more so if you're having a specific type of diarrhea where you're malabsorbing fat and you're having what we call steatorrhea. Large meals were reported to trigger a whole array of symptoms, so any combination of those classic carcinoid symptoms. So large meals tend to already be avoided by a lot of people. By the time I see them, they've often figured out that doesn't work well for them. Tomatoes, interestingly, were the highest reported trigger food on these patient surveys, more so raw tomatoes, but tomatoes in general. Amines, which I think most of you have probably heard of. And so this would be foods high in amines. This can get confusing too, because sometimes depending on what you're reading, they'll kind of mix up different types of amines, and it's a group. It's an organic compound, and it can encompass lots of different histamine, putrescine, tyramine. So it's kind of a grouping of those things. We'll take a quick sidebar to look at what types of foods those are. But essentially foods that are aged or fermented, over time, these foods can be higher in amines. So again, I don't want you to take this list home and stop eating all of these foods. If you enjoy some of these and they work well for you and they're not triggering symptoms, you can continue to eat them. And for some people, they can tolerate a small amount of some of these foods. For others, they can tolerate all of them, and somebody else might be already avoiding pretty much most of these because they've just found that over time, this triggers symptoms for them. And food diaries can be really helpful in that regard. I don't know if you've ever done a food journal or a food diary, but keeping track of what you eat and keeping track of your symptoms or any digestive symptoms, finding any patterns or correlations, that can be very helpful for me, but especially for you. You're gonna know your body the best and how it's responding to different foods. I put grapefruit on here. It is not one that is related to symptoms, but I do just want you to be aware of it. Like with lots of medications, especially when we look at cardiac medications, there can be interactions or interference between grapefruit and certain medications. So in the NET population with sunitinib, everolimus, but with this, just as with any medication, your pharmacist is going to go through with you anything you need to be aware of when you start a new medication, but that's one to make note of. And finally, the class of natural health products in general. So natural health products are essentially something that has been taken and put into a more concentrated format than you would find it in a food, right? So pills, powders, capsules, we want to be very cautious with these. They're not usually well researched, if at all, and sometimes they, again, may have interactions with the medications or treatments you're on. They may interfere with other natural health products you're taking. So if you're interested in any natural health products, please just check with us first. Talk to your pharmacist or your dietitian. We're happy to investigate that. A lot of the time, the answer is going to be we don't know, because again, there's not a lot of research, so it can be a very gray area. But we'll do our best to find out what we do know, and we just want to avoid anything that could be harmful on its own or potentially with the medications that you're on. So if those are things we want to be cautious with, what can we focus on? Or what do we want to try and include? So again, very generally speaking, small frequent meals tend to be better tolerated. So aiming for kind of that 4 to 6 meals and snacks, whatever you want to call it, smaller portions spread throughout the day. Lower to moderate fat diets tend to be also well tolerated. I will say though that I think sometimes that's because we may have other undiagnosed things going on. And so if, for example, someone does have fat malabsorption, once we get that under control and have the appropriate treatment, you should be able to somewhat liberalize or increase the fat in your diet. As well, you want to make sure that you have enough protein in the diet. Very important with all types of cancer, but also with NET tumors. And so for most patients, this means we're increasing your protein by about 20% compared to the average person, and that would be kind of the baseline we start at. In some cases, we are going to aim even higher. As well, foods high in niacin, and again, this is not across the board, but niacin deficiency is a problem in some types of NETs, and it's a B vitamin. And the good news here is that if you increase your protein foods, a lot of those foods are also high in niacin. So we can kind of check both those boxes at once, which is nice. If you're considering a niacin supplement, just be aware certain formulations of that can actually cause flushing, which is not helpful if you want to know, is that from your tumor or is that from the niacin supplement? So if you're considering a niacin supplement, again, make sure you buy a non-flushing formulation. Those are available. And even with these vitamin type of supplements, talk to your team. Is this something you need? Is this appropriate for you? Cooked vegetables tend to be better tolerated than raw for a lot of our patients that are having ongoing diarrhea specifically. Also soluble fiber, oral rehydration solutions, which I'm going to talk about on the next slide too. And then in some cases, a more diabetic style of diet is appropriate if you're having any challenges with blood sugar management, if you have pre-existing diabetes, or if you have a NET affecting your pancreas, we may need to look at adjusting the diet that way. And of course, we want to work closely with your endocrinologist or whoever's doing the medical management of your blood sugars. So we know that diarrhea is a common symptom, a common challenge. And in terms of diet management, it is similar regardless of the type or the cause of diarrhea, but we still want to know what the cause of the diarrhea is. and be working with the rest of your team to make sure that we're approaching it with the correct medication management as well, because we're not just going to modify your diet and not have all of those other pieces in place too, right? So some common things that are helpful though is to decrease the total fiber in your diet. So no one food is going to be purely one type of fiber and not another. Foods are made of combinations of nutrients, but we know it's helpful to decrease insoluble fiber when you're having ongoing active diarrhea. Insoluble fiber coming from wheat-based products or peels, skins, seeds, those types of things in general. And rather instead focusing on having a little more soluble fiber in your diet. So soluble fiber coming from oat-based grain products and more the pulp of the fruits and the vegetables. And that soluble fiber actually can help because it absorbs liquid, so it can help to make the stools a little more formed, a little more absorption of that excess liquid. Fluid, so the type of fluid matters. If you are having actual diarrhea, more than 3 bowel movements in a day, especially if they're large volume or very watery, you're not just losing water, you're losing electrolytes. And we need to make sure that the types of fluid you're drinking can actually be absorbed by the gut well and aren't just further contributing to that diarrhea. So the pharmacy ones that you'll think of or that you'll hear to help properly replace fluid losses are our lights, our Pedialyte, our Gastrolyte, our Hydrolyte. And so these are the right concentration that your gut can absorb that fluid and still be giving you the electrolytes, sodium, potassium, magnesium, things that you're losing in the diarrhea, right? So type of fluid matters. I really want to stress that. It's often people's instinct to just reach for water or I'll have orange juice, but sometimes that does more harm than good. Another time when frequent small meals and snacks can be helpful too. Those large meals are not going to be helpful in the case of diarrhea. And then certain foods may need to be avoided or reduced during active diarrhea. Lactose intolerance can be something that is transient. So if you've had ongoing diarrhea for some time, your lactase enzyme, the one that breaks down the lactose sugar, may not be working as well. And so avoiding the dairy products during that time can be helpful. But that's one where you should be able to reintroduce the dairy products if you were not previously lactose intolerant once your diarrhea is better controlled. Simple sugars, so again, thinking about the types of fluids that you're choosing, because those simple sugar drinks can make the diarrhea worse. Caffeine, alcohol, spicy foods, fried foods, these are all things you'll notice were on the other list. So that's why I put, you may be able to reintroduce some of these when the diarrhea resolves, but if those have been a trigger food for you in the past, that doesn't mean you can tolerate it now. One other thing I want to mention, if you're doing any sort of nutrition supplement drinks, like Ensure or Boost, those are already considered low lactose. So you should be able to continue those through diarrhea, but you might still need to incorporate some of the oral rehydration solutions like your Pedialyte. Okay, intestinal surgeries. Really tough to summarize in one tiny slide. It really depends what the surgeon has removed, how much, are we dealing with any bowel obstructions, are we involving the pancreas? So I really can't give any, single guidance on this. This is again where you need to have a dietitian pulled onto the team to work along with your surgeon and your medical oncologist to see what's going on. Because depending on what intestinal surgery you've had, there's different implications as to which nutrients you're more at risk of for deficiencies and how we might need to supplement your diet. And especially, if you've got an ostomy or if you have short bowel syndrome, that's going to be very much more involved. And we want to make sure that that gets managed early on. So if you don't get referred to anyone, ask to be referred. Okay, I do want to touch on pancreatic enzymes as well, because I do get a lot of questions around this. And so there can be different times when this is appropriate, not just with surgical resection or Whipple procedures, depending how much of the pancreas has been removed. So essentially what's happening here, the pancreas has many functions, as you know, but one of them is to release digestive enzymes. So you've got your protease, your lipase. Oh, sorry, that's on my next slide. And I'm not going to skip because I don't know how to go backwards. Let's see here. No, okay, I'm going to stay here. So essentially when the pancreas isn't kicking out enough of those digestive enzymes, you can get that fat malabsorption or that steatorrhea. And these are some of the signs and symptoms that you might have associated with that. There we go. So when you're taking digestive enzymes, if they're indicated, which interestingly we don't usually test for because it's much easier to just take the enzymes and see if they help with the symptoms rather than doing another test, which usually involves collecting a stool and all sorts of fun things like that. So instead, we tried the enzymes, see if it helps with the symptoms. And they're coated capsules. They are not the same as digestive enzymes that you buy at the health food store or even the pharmacy these days. It's not the same as bromelain from, pineapple. So you need a prescription for these digestive enzymes for them to be effective and to be the right ones. You also need to take them appropriately. So the point of the enzymes is that they are going to be in your stomach when you need them and move through into the small intestine along with the food. So if you take your enzymes after your meal, not going to catch up. So take them before your meal or shortly or right at the start of your meal. And they need to be taken with any solids or liquids that contain fat, protein, or complex carbohydrates, okay? So even with your Ensure or your Boost, or even if you're having a snack of yogurt and fruit, you need to take your digestive enzymes with any of those types of foods. And we really do just base the dose on symptoms, and it might change over time. So you may adjust this as you go. And my apologies, I did not tell you the other times that we're thinking about these enzymes, so I'm going to go back to that for a second. So with the surgeries, when we know the pancreas is involved that way, but also if you have a mass in the pancreas that has not been resected, but is a large mass, especially maybe more so in the head of the pancreas, we're going to be thinking about, are you having symptoms of steatorrhea? Could digestive enzymes be helpful in that case? And then another population within NETs that we think about these for, if you've been on long-term somatostatin analogs, so if you've been on your lanreotide or your octreotide for some time, we can also start to see these symptoms. The literature varies a little bit, but about 20% of patients in that scenario, they say may need digestive enzymes. So there can be a few different times when we might require these. And also to be thinking about, if you've been malabsorbing fat, have you been malabsorbing fat-soluble vitamins, right? So we want to make sure that you have adequate stores of vitamin A, D, E, and K as well, our fat-soluble vitamins. Okay, and then just to bring it back again, where we don't want to unnecessarily restrict foods, if you're not having symptoms that are affecting your eating, if you don't have foods that seem to trigger symptoms, we're going to follow the general cancer diet guidelines, okay, which are going to be to achieve this healthy balance and variety in the diet. And these would be the American Cancer Society guidelines. We have recommendations as well from the American Institute for Cancer Research, or the AICR. And so we're going to try and incorporate these healthy foods and maintain that good lean tissue and muscle status as well to help you get through your treatments well. So I think, as we've seen this weekend, this is a very heterogeneous population. No two NETs are really exactly the same. No two patients are exactly the same or with the same symptoms, and you know that better than me. But I would just really encourage you that if you're struggling with eating, or if you think you're not absorbing what you're eating well, or if you're losing weight without trying, please ask to see a dietitian. And there are not necessarily a lot of neuroendocrine tumor dietitians. We're not usually going to be a specialist only in that area or dedicated only to the NET team. But I think if you can find someone that is willing to learn and willing to communicate with the rest of your team, that we can really help you to achieve better nutrition status and to help you get through the rest of your treatments a little bit better. So don't be afraid to ask for what you need. And as dietitians, we are here for you. We are part of your team, and we want to do what we can to learn alongside you and to help you have better quality of life. So thank you again so much for having me today, and I will pass it back.
Oh, you know what? Maybe if you want to have another position. Our next speaker, Dr. Breffney Hannon, leads a palliative care program at the Princess Margaret Cancer Center and is an associate professor at the University of Toronto. Her research interests include early palliative care as well as caregiver supports. Dr. Hannon.
Hi, everyone. Good afternoon. It's so lovely to be here this afternoon and to get to see you in person. My previous experiences with this conference has all been virtual, so it's lovely to have an in-person event today. And I want to sincerely thank you all for sticking here until the bitter end. I know it's been a really jam-packed 2 days. It's a gorgeous day outside. I'm sure you're itching to get out into the sunshine. So I really appreciate everyone's time and attention, not least because it's a talk on palliative care, which is often not everybody's favorite thing to talk about. So thank you for bearing with me. I hope this is going to be worthwhile. So I'm going to chat to you a little bit about the term early palliative care, which might sound a little bit like an oxymoron. And I'm also going to describe how palliative care might fit into your personal treatment plan or that of your loved one, as well as make suggestions about when or how an introduction to palliative care might be helpful. So I think it's always really interesting to start by clarifying the definition or the meaning of the word palliative, because of course there's a lot of stigma and taboo that we're going to talk a little bit about today, that's really entrenched in the word itself, and it can be a very frightening word to hear it. So when I meet patients, and even when I'm talking to some of my colleagues, I'll say to them, hey, do you know what the word means? And nobody ever knows. Does anybody know what the word means? Who hasn't looked at the slide already? And it actually comes from the Latin word pallium, which means to cloak or to cover. So the word itself has nothing negative when we think about the connotations with the end of somebody's life or death or dying. And rather, it was initially designed to talk about the approach we take to cover up the symptoms of an illness when we can no longer cure it. So maybe not so bad after all. To look at a more specific definition, so the official definition through the World Health Organization has changed a lot over the past years, and this is the most recent one. Of course, as with any definition, it's long and it's wordy, so I've tried to bold the bits that I think are particularly relevant. So again, you'll see that it talks about things of quality of life. It talks about patients and their families, so recognizing that most of our patients are not going through this on their own, that they have a network of friends and family who are there to support them. It talks about preventing and relieving suffering by means of early identification, impeccable assessment and treatment of pain and other symptoms, and it also recognizes the multitude of these problems. So it's not just physical, it can be psychological, it can be social, and it can be spiritual. So again, maybe not so bad as you'd originally thought. And, you know, palliative care has changed a lot over the past 10, 15, 20 years. The image on the left, I think, is what a lot of people still think about when they think about palliative care. They think about the end of somebody's life, when they're very close to the end, when they're in bed, they're dependent on other people, they're not able to do very many things for themselves. The picture on the right I took from an advertising campaign from Australia from a couple of years back, where the person is saying, palliative care keeps me going all the way down the coast. And I know that this is a cartoon and it's supposed to be sort of uplifting, but it is very much where we see ourselves as palliative care providers now. We've started to move away from the end of people's lives, although we do still support people until the end of their life. But our mandate is now much more about being life affirming and helping people to live as well as they can for as long as they can, and to keep people going, as you can see here. And so to put that in a more medical or healthcare type graphic, the old or traditional model of palliative care is what you see on top, where patients would continue with their treatment from their oncologist, and that treatment would eventually stop, and there would only at that point would you get referred to a palliative care physician or a palliative care team. So there was a very clear demarcation line where active treatment stopped and palliative care became involved. We have thought for a long time that we've got a lot of skills that we can offer much earlier in somebody's illness. So in parallel with your treatment from my wonderful colleagues who we've heard from over the course of the weekend, while patients are still going through treatments, that we start to get involved. And maybe in the beginning, it's just about talking about some of your symptoms. And then over time, our involvement becomes, you know, more intense, and maybe we take over more of a leadership role in that. And again, we continue to follow patients even when their treatment has stopped. But it's not the stop-start model like you see at the very top. It's a bit more of a phased approach. And really over the past 14, 15 years, there's been a lot of research that has shown that early palliative care in conjunction with your oncology care can have some positive impacts for patients and their families. The first one of these is the one at the very bottom, which looked at patients with lung cancer. So, I mean, different to what we're talking about today. But that study really hit the headlines because it showed that patients who had early palliative care involvement along with their oncology care actually lived for longer than patients who never saw a palliative care physician or only saw one at the very end of their life. So that was a very striking finding, and it caused a lot of attention. There have been further studies that have shown this over and over again, that patients who see a palliative care team earlier in their disease have better quality of life, better satisfaction with care, their symptoms are better attended to, they have less aggressive care at the end of life if that is their wish, they're more likely to receive the care they want at the end of their life, and their caregivers also have better outcomes in terms of quality of life and satisfaction with care. Now, one of those studies was done by our team here in Toronto, and that included patients with a variety of tumours, not just lung cancer. So we took this one step further and we thought, okay, well, what is it that palliative care does? What is it that we do? What's the secret sauce? So we asked patients who had received early palliative care as part of our study, what were the elements that they thought were helpful for them? And these were the 4 things that they told us. They said that the palliative care team provided more prompt and more personalized attention to their symptoms, that it provided more holistic support for them and their families, that it was a different lens that allowed them to think about the future and to provide some guidance around decision making. In other words, I think medicine has moved a lot in the past number of years, where we've all become so super specialized that, as you can see here on this cartoon, depending on what part of the elephant you're looking at, you might think it's a wall, you might think it's a rope, you might think it's a snake, you might think it's a tree. Our job as the palliative care team is to stand back and say, hey guys, this is an elephant, and here's how we're going to approach this problem from a broader strokes perspective. We also interviewed patients and their caregivers who did not take part in this study, so the ones who just had their usual oncology care and never saw a palliative care physician or saw them quite late. And we asked both groups, so those who did have early palliative care, those who did not have early palliative care, what do they think when they heard the word? And of course, in both groups, at the beginning, they had quite negative perceptions, a little bit like we alluded to at the beginning of this talk. So they saw it as being very much rooted in the end of life, loss of hope and loss of independence. But those who received early palliative care had a bit of an epiphany and said, actually, I can totally see now how this is applicable to me. Maybe I'm not quite at the end of my life yet, and that's great, but I can see how the definition of palliative care can really apply to me at this moment of time in my illness, and how it can improve my quality of life, my symptoms, and those of my family and my loved ones also. And so on the back of a lot of this research, the American Society of Clinical Oncology and other oncology organizations published a recommendation about 6 years ago to say that patients with advanced cancer should receive dedicated palliative care supports early in their disease course while they're still undergoing active treatment. So not waiting until we've exhausted all of those treatments. And there's been a number of campaigns, like you can see here on the right, to try and debunk some of these myths so that it's not frightening or scary if your oncologist or your clinical team starts to talk to you about palliative care. Including this from my own colleagues. So this was published in JAMA last year and really tries to, again, debunk some of these myths about palliative care. And here they liken palliative care as a bit of a safety net or an umbrella. So on the top, you've got a patient and their loved one. They've seen their oncologist, they've gotten some bad news, but they're okay for now. And a few months later, things start to get a little bit worse. The metaphor here is it starts to rain. At that point, their oncologist runs after them and hands them an umbrella and says, hey, this might help. The umbrella being palliative care here. And they say, thanks, I wish we'd had this sooner. Of course, we know that having an umbrella in your purse or having an umbrella in the back of your car is always a handy thing to have because you just never know when it's going to rain, especially if you're from Ireland where it rains all the time. So in this second graphic on the bottom, when they receive some bad news about their illness, the oncologist hands over the umbrella and says, hey, you might not need it just yet. It might not feel like it's exactly what you need right now, but just in case, I want you to hold on to this and to have it on hand so that a few months later, when things change, you feel pretty glad that you'd made that connection or had that umbrella in the first place. So it might beg the question, when is the right time? I'm obviously suggesting that sooner rather than later is better. When is the right time? Well, it depends. And a number of different experts have come up with different criteria for when might be a good time to be referred and make that initial contact with a palliative care team. Some people have said maybe based on the stage of your disease, a change in your disease, maybe new metastases or a different treatment option. Based on your symptoms, if you've got moderate to severe symptoms, those of you who come to the hospitals, we know we're always asking you to fill out those symptom questionnaires every time you come. We've started to use those symptom questionnaires now to automatically trigger a referral to the palliative care team if they reach a certain threshold. or based on your request. As patients and caregivers, it is certainly within your goals to request a referral to palliative care if you think it might be helpful for you. And it's not to say that our oncology colleagues don't do a tremendous job, they do. But those of you who attend oncology clinics know how busy they are, how overwhelmed they are, how crowded they are. And it's not always possible to go in depth into some of the symptoms that you're experiencing, or to have a truly comprehensive assessment with your loved ones there too. It will also depend on the institution that you're attending. So some hospitals are very fortunate to have lots of palliative care team members who can support patients. Others have a different model. So it does very much vary from hospital to hospital. But if in doubt, ask your clinical team, ask a nurse or an oncologist, your surgeon, your radiation doctor, if a referral to palliative care might be right for you at this moment in time. I know we're short of time, so I'm going to stop there now and I'll be happy to answer some questions. Thank you so much.
Thank you, Dr. Hannon. Any questions for our speakers here? Lindsay and Dr. Hannon? No? So I will just say my thanks to all the audience that have come here on a beautiful Sunday afternoon and for the 2 days that you spend your weekend here. I just wanted to re-quote basically what Dr. Law has said. You're our inspiration for the physicians. I think that's when we have a positive outcome, it encourages us. When we have not so good outcome, it makes us think hard, go back, collaborate, have our physicians go back and try and find new treatments, scientists work with the scientists. So I think it's very important to understand where you stand in making us do what we do. So thank you very much for being here and encouraging us. And I'll give it to Amanda.
So one last big thank you to all of our amazing speakers today for your fantastic presentations and our heartfelt patient stories. Just thank you all for your support of Cnets and the patient community. And thank you to Dr. Yelamanchili for keeping us on track all day. Not an easy job, but we're wrapping up on time, so success. And this brings the 2023 National NET Patient Conference to an end. I hope you found this event helpful for your journey. And thank you once again to our sponsors for supporting this important event and events like these for our community. And so just before you go, a couple of really quick reminders. If you'd like to join our 2023 fundraising efforts and help us hoof it for neuroendocrine cancer research, please visit our website at cnets.ca to find out how to join a team or start your own. If you need support, please reach out by email, by phone, through the Facebook support group or any of our social media channels. And also please keep updated on Cnets happenings by signing up for our mailing list, which you can do so on our website by clicking on Stay in the Know. And finally, your feedback is so important in helping us create these events. So please complete the conference evaluation for day 2. The link is in your package. And we'd love to know what you liked, what can be improved, as well as any topics or content you'd want to see at future events to help us make these as helpful for you as possible. And that's it. So on behalf of Cnets, thank you so much for spending your weekend with us. Hopefully you still can get a few hours of sunshine leaving here today. So thank you. Well,